Good morning. Welcome to Bradford Health Services first CEU event for 2021. I am Sherry Schaefer, Corporate Director of Clinical Operations at Bradford Health Services, and I will be introducing the session and moderating the Q&A portion for today. I want to thank everyone who is joining us today as we have participants that are coming online with us. Bradford will be hosting several contact hours over 2021, so make sure you check out our website for upcoming events that we have scheduled. I'm also going to include a direct link to our events page in the Zoom chat for you to check out any other upcoming scheduled events that we have. Before I introduce today's session, I want to share some important information with you. You are viewing this in webinar format, which means that you can see the presenters, but your video and audio are off. Please use either the chat or the Q&A functions located on the bottom of your screen to ask questions regarding topics discussed or specific questions that you may have for one of our presenters. At the end of the presentations, we will have a panel discussion where questions received will be answered at that time. Please note that you will receive a post-session email, including a link to materials presented and referenced today, as well as a link to a video recording of today's presentation. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services is providing those contact hours at no charge to you. After the conclusion of today's presentation, you will receive an email with a link to an evaluation. You must complete the evaluation in order to receive credit for your participation today. Certificates will be sent out via email for those who complete the evaluation within 1 week. We were expecting a large attendance for today's session, so please be patient regarding the education components, as we only have 1 staff member who usually processes the evaluations and certificates. Finally, if we experience any kind of technical difficulties today, please stand by while we do our best to resolve them. So now that we've gotten our housekeeping issues out of the way, I would like to introduce our session. We're excited for today's session on medication-assisted treatment, or MAT, as it's commonly called, and clinical applications. We have 3 excellent presenters today who are all very knowledgeable in this topic. They will share information on MAT and provide unique perspectives from their own areas of expertise. I'm going to briefly introduce the speakers, but allow them to provide more specific information regarding their backgrounds when it's their time to actually talk. Our first presenter is Dr. Brett Ballou. Brett serves as Director of Pharmacy at our Warrior Inpatient Facility. He has been with Bradford Health Services for a total of 7 years, but joined us full-time 4 years ago. He will share with us today the pharmaceutical role in MAT and the science of addiction. Our second presenter is Dr. Amanda Bullard. Amanda serves as our Director of Nursing at our Warrior Inpatient Facility. She's been with Bradford Health Services for 12 years, and she's going to share the role of MAT from a nursing perspective and looking at the actual medications for medication-assisted treatment. Our third presenter for our educational portion is Zach Ludwig. Zach is a licensed professional counselor in 3 states and serves as the Director of Regulatory Services for Bradford. He's had multiple roles within the company over his 10-year tenure, and he will share information regarding the clinical role when working with MAT patients. All 3 presenters will be available during the panel discussion to answer any questions you have, in addition to Jennifer Duncan, who is our MAT nurse at our Warrior facility. She has been with Bradford for 20 years. A little bit about Bradford. We have been in operation for over 40 years. We do have inpatient treatment as well as outpatient treatment programs in Tennessee and Alabama and Arkansas. We are based on 12 steps, but we do utilize MAT in our programming. So a couple of disclosures, or actual, we don't have any. There's no personal conflicts or nothing to disclose regarding this seminar. Our objectives today is to gain an understanding into the neurobiology of addiction, understand the scope of the opioid epidemic, understand effective treatment needs of persons with opioid use disorder or OUD, understand the role of counseling OUD patients, identify the goal of MAT in treating OUD, and defining the role of partnering addiction counselors with clients and healthcare professionals. So I hope you enjoyed today's presentation. I will see you again for the panel discussion following the presentation, and I am going to now turn it over to Dr. Ballou.
All right, thank you, Sherry. I appreciate it. So just a brief overview of my background. I'll be covering an introduction to the neurobiology of addiction, but a brief overview of my background.
Brett, I
I
can't
became
hear you.
hang on. Can y'all hear me?
I can hear you, Brett.
Okay.
Looks like a lot of our folks on the call can hear you. So I say proceed, and we'll figure out what's going on with Sherry's.
Okay.
Thank you.
Okay. So just a brief background about me. My professional background is I've been a pharmacist since 2011. 14 of my years as a pharmacist in pharmacy, I started in 2005 as a pharmacy technician. 14 years of my background are with CVS Pharmacy. So most of my background is actually with retail. I started part-time with Bradford 7 years ago. And as Sherry said, I started full-time with them about 4 years ago. I've been a pharmacy preceptor for pharmacy students since 2013. And I actually started the pharmacy student rotation we have currently going at Bradford in 2017, I believe, is when we started it. The pharmacy students absolutely love the rotation because we don't learn very much at all about pharmacy about addiction while we're in pharmacy school. And so it's a completely different side of pharmacy for them. And like I've told them before, it's something I didn't even know was an option for me as a pharmacist. So moving on to characterizing and starting with the neurobiology of addiction, the best thing to do is to characterize what addiction is first. So what is addiction? The primary definition of it, or a short definition of it, is it's a primary chronic disease of the brain reward system for motivation, memory, and related circuitry. So basically, when I present this to students or anybody else, I tell them to think about addiction like any other chronic disease you may experience, because it's a lifelong issue for patients. Yes, patients can get in recovery, but patients are always striving to stay in recovery. So it's a lifelong chronic disease that they have to deal with. The best example I usually give people is you think about something that requires maintenance on a daily basis, and that would be a diabetic patient. If they don't monitor their blood sugars and maintain what they're supposed to, they can have issues. So if a patient who is in recovery doesn't monitor their daily lives and keep things in order, they can struggle with issues too. So dysfunctions in the circuits in the brain can lead to biological, psychological, social, and spiritual manifestations, which we'll cover later in the slides. And what you'll see in a patient is them pursuing reward and or relief by the substance that is their preferred substance of use. So that's just kind of a brief overview of what addiction is. We have what we call the ABCs of addiction. So it's characterized by patients and their inability to consistently abstain from a substance. So many people can do things and shut it off when they need to. An addicted patient, say someone who starts off socially drinking or who has an elective surgery has some kind of elective surgery or necessary surgery and is treated with some kind of pain medication. Once they start down that road, they can't shut it off. Their brain will not allow them to shut it off. Whereas most people can say, okay, I'm past the surgery, I don't need the pain medication anymore, or I have to control my alcohol intake. I only do it when I'm socially out. So one of the hallmarks of them is they cannot abstain from it. Another hallmark is it impairs their behavioral control. They cannot control their behaviors. Again, you and I, for the most part, or most people listening to this, I would assume, have an ability to control their behaviors, whereas the addicted patient can't necessarily do that. Craving is another thing. These patients crave whatever their drug of choice is. So if it's alcohol, they have a craving for alcohol. If it's a certain opiate, they have a craving for opiates. And then a big hallmark of it, and this is what I stress when I'm teaching my students, is they do not recognize, or they have a diminished recognition of the problems that their behavior is causing. So they can't see what it's causing, whereas the people around them that are closest to them can see all the issues it's causing. And then the other thing that I tell students, and I try to teach them to look out for it in a retail setting, because once I started working with Bradford, I could actually see this in some of my patients at CVS, is they have a dysfunctional emotional response. So when you approach them about this, where they may have been a cool, calm, collected person that could rationally listen to what you were saying before, if you try to approach them about their addiction, they'll have an uncharacteristic response to it. They may lash out. They may, they may tell you that you're wrong, that you're the one that has a problem, you just don't see it, things of that nature. So, and like many chronic diseases, there's cycles of relapse and remission. So these patients will have, some patients can beat it and stay in remission for the rest of their lives. Some patients have an endless cycle of, they go into remission, they relapse, they go into remission and relapse. And just like any chronic disease, if addiction's not treated, ultimately it progressively gets worse, and it can result in disability for a patient, or it can result in their premature death. So what are some other defining characteristics, or what are other things we look for in addicted patients? Power of external cues. So what triggers them for a craving or drug use? They increase the frequency of other potentially addictive behavior. So one thing we see, or one thing I can relate that to, is patients who are addicted to, say, video games or games of that nature. That may not necessarily directly relate to their drug addiction, but it can be an increased side effect of the drug addiction. They'll just, every other addiction they may have amps up in their life. And the memory of their previous euphoric or dysphoric events. So when people have addiction issues, a lot of times all they remember is the good things. The dysphoric events sometimes get overshadowed by, hey, I did this and this felt really good. And they don't remember, oh, I did this and I wrecked my car, I totaled my car, or I did this and I ended up in jail. All that gets overshadowed by the great feelings that they had when they were doing whatever it was that gave them that high. And we talked about this a little bit, but the persistent risk and or reoccurrence of relapse, it can be caused by an exposure to the rewarding substance. So if they keep getting exposed to whatever it was that gave them that original high or that original feeling, they keep going back to it. It's just like I tell all my students, if you do something that feels really good, your brain lays down a memory that, hey, I did this and this happened and it felt fantastic. So you keep trying to seek that again, whether it's something you did in a sporting event, whether it's something you did exercising, a goal you've been trying to achieve, your brain lays down a memory of that and it tries to recreate that as much as it can. There's exposure to environmental cues, so maybe stress at home or things of that nature that trigger people to, use or whatever it may be at home. And then emotional stressors too. So if they have a job that's very demanding, that may be a trigger for them to go home and drink or use to escape. So they use it as an escape from their everyday lives at times. So moving on, more defining characteristics of addiction is a significant impairment in their executive functioning. So the best way to describe that is they have problems with things that maybe they could control before. So maybe their perception of reality is skewed. Maybe their ability to learn new things is skewed. Impulse control, compulsivity, and judgment, all those things will be skewed in the addicted patient as time goes on. And it gets worse and worse if the patient doesn't seek treatment. And their threshold to change their behavior, despite the concerns of people that are around them, becomes very low because they don't see the problem. All they see is, I do this and it feels good. I don't see how it's affecting those around me. And the lack of concern for the problems they are causing and the growing complications that their addiction is causing. So if they've been arrested multiple times, that may not factor into them. They're like, I don't care that I was arrested, or I don't care that this happened. I do this and it feels really good. And learning that addiction is more than a behavioral disorder is important for patients. So it includes patients' behaviors, obviously, but their cognitions, their emotions, and their interactions with others. That's probably one of the biggest things I have seen in my practice as a pharmacist in retail were patients that I saw that ended up going down that road of having a problem, where patients, or the patients I noticed it in the most now that I can look back on it, are patients I was closest to. Their interactions, even with me, and I wasn't that necessarily as close to them as their family, would change over time. And that goes into their ability to relate to members of their family, their community, themselves, and things that, transcends their daily experience. They have issues relating to those around them, even the people that they're closest to. So what kind of manifestations, behavioral manifestations, do we see in these patients? And we've kind of covered parts of this already, so I'll go over some of it briefly. An excessive use or engagement in the addictive behaviors. So these patients seek out using whatever substance it is that is their substance of choice, and they use it at higher and higher frequencies as their addiction progresses if they do not, see what the problem is or seek some kind of treatment. They lose more and more time in substance use or recovering from the effects of the substance use and engagement in addictive behavior. So where it may start out as, oh, I did this one time and it felt good, but I won't do it again. Oh, I did this one time and I lost an hour of my life, 2 hours of my life. Oh, I called into work today because, I'm using and I can't function at work. It just progressively gets worse. And the use and engagement of their addictive behaviors, which could have been caused or exacerbated by substance use and related addictive behavior. So that just gets worse and worse. So I tell people all the time, like, people have addictive personalities, but they can control them. And I would be a prime example. I have addictive behaviors and personalities, but I have the ability to say, okay, I need to stop doing this, or I need to, shut this off. Whereas somebody who has a substance use disorder or a true addiction cannot shut that off. They can't say, oh, this is causing issues, I need to stop this. There are a lot of people that have addictive behaviors and addictive personalities, but they can control it and say, hey, this is causing issues, I need to shut it off. The addicted brain, the true addicted brain, cannot shut that off or say, hey, this is causing issues, I need to quit doing it. And ultimately, an increase in behaviors that solely focus on rewards from their addiction. So all they're looking for is the reward that they get from their addiction and their substance of choice. Other things that behavior complications, and again, these are things that I saw in my practice as I learned to recognize them. It's an impact on social and occupational functioning. So they have problems developing interpersonal relationships, or the relationships that they've had become strained because of their addiction. Neglect of responsibilities at home or school or work. Those are probably some of the most hallmark things that I saw in my patients, and unfortunately at times my coworkers, was I would have a worker that was a fantastic worker before, but as their addiction took over, their responsibilities at work, home, school, they just went by the wayside because that wasn't what was important to them. Recurrent physical and psychological problems. So patients that stay in addiction have recurring problems that just never seem to go away or get better. Some of these patients, and a lot of them, have a desire to control their behavior, but they can't do it. They try on their own sometimes, but they're not successful, even though that desire may be there. Their substance of choice has taken over their life, or that addictive behavior has taken over their life, and they cannot get away from it anymore. And then the apparent ability to stop what they're doing and seek help or seek some kind of action that will help them get better. Even though they realize what the problem is and that it's causing a problem, they can't turn it off, they can't stop. So what do we see mentally? Like, what kind of cognitive changes do we see with these patients? Obviously, the preoccupation with substance use that we've talked about. The addiction takes priority over all aspects of their life. So if church used to be their priority, that starts to fall by the wayside. Their religion will start to fall by the wayside. If if a sporting event or something else in their life used to be, hey, this is top priority for me, that becomes less and less important as the addiction becomes more and more prominent in their life. And their outlook on the relative benefits and problems that are associated with their addiction, those become skewed. All they see are the benefits. When I do this, I feel this way. I get this type of feeling. I get this type of reward when I do this, and they don't see, oh, when I do this, this causes hurt to my spouse, this causes hurt to my children, this causes negative impact at my job, things of that nature. And then they want to blame the issue on others. They don't want to take responsibility for it. They want to blame it on others. They want to blame it on other life factors. Oh, you don't understand. I had X, Y, and Z happen in my childhood. That's why I am the way I am. You don't understand just because you're the one that has the problem. I'm not. That's one of the biggest issues we can see with our patients, or in this patient population, is that they want to blame others for what's going on in their lives. They don't want to take responsibility for it. And then talking about emotional changes. So what do we see emotionally from these patients? Increased anxiety, dysphoria, and emotional pain. So they become more anxious as their addiction takes over, because what am I going to get caught doing? What could happen to me? They have more emotional pain because there is an internal struggle with many of these patients of, I know I shouldn't be doing this. Why can I not turn it off? Stressors in their life become way more sensitive to stressors in their life as the chemistry in their brain changes. So things in their life may seem more stressful when really nothing has changed, but their brain chemistry is getting altered. So what they'll perceive their lives as becoming more and more stressful when really nothing has changed that drastically. And then they can't identify feelings or distinguish between the feelings of, what's their bodily sensations and emotional arousal, or describing feelings to other people. They can't relate their feelings as to what's going on. They know they feel a certain way, but they can't relate it to anything or describe it to people around them adequately. And the big thing to know is, like, dysfunction of the emotional state is present in most cases of addiction because of their persistent engagement with addictive behaviors. So the more and more that they interact with their addictive behaviors, the more and more that they can have issues with their emotional state. So next, we're going to talk about, there's some predispositions to addiction and things that can actually predispose people to addiction, and we're going to cover some of that in this next section. So there's a trifecta of variables that can predispose people to addiction. One of the major ones is the agent. So what are they using? Usually this requires reinforcement. And when I say that, is using the agent over and over predisposes people, or can predispose people to addiction. So even somebody who doesn't necessarily have an addictive personality or addictive behaviors, if they have to constantly use something, i.e. opiates for some kind of pain control, over time they become addicted to it. And the properties of the drug itself can make it more addictive. So we spent years and years in the pharmacy world, and chemists and scientists all over the world spent years trying to figure out, especially for opiates, how can we make them work better, faster, and be more effective? One of the side effects, or one of the unforeseen complications of that, is as they did that, they also made these drugs more addictive, because if I can take pill A and I get results in 20 minutes, but I can take pill B and I can get results in 5 minutes, I'm going to opt for pill B if I can get the same results in 5 minutes. And that was science's view of it. If we can make it better, it's going to be better for the patient. But a side effect of that is it can also reinforce the addictive behaviors of the patients. And then as far as the patient themselves goes, they can have issues with metabolism. So we have what we call super metabolizers of a drug. Super metabolizers of a drug can take, if I give patient A 10 milligrams of a medication and it will last in their body or work for, say, 4 hours, but then I give patient B the same 10 milligrams of the medication and they are a super metabolizer of it, it may only work an hour in their body because their body's predisposed to break down whatever medication that is faster. There can also be patients who have tolerance to the drug and they're just born with it. And that's seen as, we can take two people of their same relative size, relative physical build and everything, and give them the same level of pain medication. And one patient, it'll control their pain. The other patient, it won't. That's because the other patient is not as sensitive to it and they require more drugs. So therefore, they may have a tolerance built up already that they were just born with. And then receptor densities. So if I give a patient an opiate and they have a higher opiate receptor density in their body, they're going to get more effect from that than your average person. So again, if I give 10 milligrams of a medication to a normal patient versus a patient who has a higher receptor density, the normal patient is going to get the normal response, but the patient with a higher receptor density is going to have an over-exaggerated response to that medication because they are predisposed to, just by their chemical makeup in their body and their receptor density. And then there's issues that most people are aware of, but just to cover them for completeness, the environment, so peer pressure of using the drugs and then stress of the environment. But all this together creates a trifecta of predispositions to addiction for a patient. One of the biggest things, and I covered this a little bit in the last slide, is the traits of the agent. So the property of the substance to make the user want to use it again is usually involving the brain chemistry to produce a high. So certain agents have the ability to produce a stronger, faster high than others. So what properties make this desirable? So what are we looking for? If we're looking for it from a pharmacy standpoint, rapid absorption, rapid onset of action. So if I'm trying to help a patient, if I can get the drug to absorb faster and to onset faster, in my mind, that is good for the patient. But again, that can also be bad for the patient, as in it can reinforce those addictive behaviors because they are using to get that high, and the faster they can absorb it, the faster they can get the onset of action, the more it's reinforcing those behaviors. So an example is a cocoa leaf versus cocaine. The cocoa leaf is what the cocaine is derived from. You can actually wad the cocoa leaf up and chew it and get the same effect, but it doesn't happen as fast versus powdered cocaine. You can get an effect much faster. So that's just one example of what I'm talking about when we're talking about agent traits. And then when we talked about host traits, genetic predispositions are probably some of the best explanation as to why some patients struggle with addiction over other patients. So genetic polymorphisms, like their gene code is just different from other patients, and that predisposes them to addiction because maybe they have a heightened response to the drug. Maybe they're a super metabolizer, which requires them to have more of the drug. The innate tolerance or intolerance to medications we talked about. There's actual alterations, which we'll talk about in a little bit, of the mu-opiate receptors in some patients that makes them more disposed to or predisposed to being an addicted patient. And then personal traits or associations prior to the disease state. So just things that were going on prior to the patient, engaging in their addictive behavior or their addictive behavior taking over. So innate tolerance. What are we talking about when we say innate tolerance? So one example would be some people have the ability to, or an increased ability to tolerate alcohol versus other patients. So one of the lectures I used to listen to when one of our providers was giving it at Bradford, he would talk about in high school, you may have a group of friends that go out to drink, and two of the kids, if it's three kids, two of the kids may only tolerate a couple of beers and feel buzzed and feel, like they don't need to drink anymore. Whereas the other friend may drink an entire six-pack and be like, hey, the party's just getting started for me. So that person, even though in high school, they would consider that cool, or, they can tolerate alcohol better than their peers, it's actually a precursor to problems down the road for them. So it's usually common in first-generation blood relatives of alcoholics, and it predisposes people to becoming alcoholics as it takes more and more alcohol to obtain the effects. So i.e., he drinks a 6-pack and he's just now starting to feel good, doesn't even feel buzzed. They drink a couple because they've never drank before and they don't feel like they want to do it anymore. And then protective effects can be an innate tolerance to alcohol as well, and that can lead to adverse effects from drinking alcohol. So can be an innate intolerance, I apologize, to alcohol. So sometimes people drink just a little bit and they get flushed really easily, or it makes them feel extremely sick. That's a negative consequence to them drinking, and they say, I don't want to do that again. So that's actually a protective factor some people have built in. And we see that certain populations of people have more issues tolerating alcohol than others, and so you don't see maybe as high a rate of alcoholism in those populations. I mentioned earlier mu-opiate receptor changes. So there's a specific gene in our body that codes for the production of the opiate receptors, and it's called the OPRM1 gene. That gene codes for the production of the mu-opiate receptors in our body. So alterations in that gene changes how many opiate receptors are produced in the neuronal membrane. So if there's an alteration that decreases the amount of opiate receptors a person has, they're not going to get that same high effect from medication that, say, somebody who has an alteration that causes an increase in production of the receptors. So that can be a good thing for them, but it could also be a bad thing because it could be that they require more medication to get the same effect, which i.e. can lead down the road to they have more of an addictive behavior. And in the same factor of saying an uptick in alteration or production of these is not always a bad thing, because sometimes people get that increased feeling from those medications. They're like, oh, I don't like that, I'm going to step away from it. So the person that produces more receptors will have a more euphoric event when using opiates, and that can encourage overuse. Like I said, it can also discourage people from using because maybe they get that feeling and they're like, I don't like this because I'm not in control. So sometimes it can be a protective factor, but more times than not, it's a negative factor for the patients. There's still studies ongoing. In the last few studies I've read, there's no concrete evidence that says that patients that have addiction more commonly have polymorphisms in this production, or in this OPRM1 gene that causes the production, but there's still studies ongoing. If I was hedging my bets, I would almost say that patients who have addictive potential have a alteration in this gene that causes a higher uptick in mu-opiate receptor production. But again, the studies are still conflicting on it, but we will see as time goes on. I haven't found any concrete evidence yet that suggests that addicted patients have an uptick in this gene alteration. So I mentioned protective factors and risk factors earlier. So kind of what are some protective factors for these patients and what are some risk factors for these patients? So protective factors include close bonding to school and community. So a sense of community is great for patients, and that helps protect them. Protective parents who kind of keep an eye out for their kids and, you know, provide a loving, nurturing home. Appropriate parental reward and punishment. If it's too far one way or the other, that can lead patients to addiction, because if the parent is overly rewarding, the kid thinks everything they do is fine. If a kid is overly punished, they think they can't do anything right, so what does it matter? And patients who live above the poverty limit are all factors that help protect patients. But what are kind of some of the risk factors? So if patients have issues with friendships or antisocial, that can be a risk factor. Lack of parental supervision, the parent that's just like, hey, do whatever you want, I don't care. Aggressive behavior as a child has been shown to also have an issue. Family history of addiction, we're learning more and more how that plays a role in addictive patients. And then if they have another substance use disorder already, that can obviously lead to an addictive issue with whatever substance down the road. When we talk about environmental traits, so what are some of the environmental traits that our patients have to deal with? So peer pressure is one. So associating with people who have used drugs. If you want to be seen as part of the in crowd, maybe the in crowd that you think is the cool kids are people who use drugs. By wanting to associate with them, or peer pressure to associate with them can lead patients down a road of addiction. Societal norms, living in an area where drug use is just, that's a way of life. If that's what you see every day, if that's what you deal with every day, you're like, this is normal. Just as if you grew up in, small town America where it's common to know everybody and then go to a big city where it's not, that's a societal shock to you. So if you grow up in an area where drug use is just how things are, then that's what you're used to seeing. And then poverty level, it's shown that lower income is correlated with drug use, and that goes back to when I talked about earlier, patients trying to escape their daily lives. If they can use something to escape that daily life, i.e. poverty, they see that as a positive. All right, so neurotransmitters and receptors involved in addiction. Some of the key players in the brain that we need to cover are the mesocorticolimbic dopamine system, and it's activated by a rewarding stimulus. There's also an area called the medial forebrain bundle. It includes ascending and descending pathways, and it connects the ventral tegmental area and the basal forebrain. The ventral tegmental areas are the site of the dopaminergic cell bodies, and that'll become important later because the site, if we can get drugs to act in this area, that increases the reward pathways. And then the basal forebrain includes the nucleus accumbens, the olfactory, tubercular, and frontal cortex, and the amygdala. But basically, what this picture over to the side shows is kind of the cycle of addiction. So they have a preoccupation, anticipation of it, they binge, intoxication, withdrawal, negative effects, and that's the continuing cycle. All these areas are involved in that. And then the next slide kind of shows these areas and kind of where they function and what kind of functions they have, and when we get drugs to act on these systems. So looking at the prefrontal cortex and the frontal cortex, that's where we have areas of planning and judgment. When we're looking at a reward system, the nucleus accumbens, the medial forebrain, the ventral tegmental system, and then our emotional conditional effects are all controlled by the amygdala. So when we talked about the ventral tegmental area in the brain, if you look at where it is and all the projections it has out into the body, you can see why when people use drugs, it affects all these areas because it projects into the prefrontal cortex and the frontal cortex, and that can inhibit a patient's planning and judgment. It affects the nucleus accumbens and the medial forebrain bundle, which is where the reward pathways are stored. So if we can get a drug to act on a dopamine system, and opiates cause a release of dopamine in our body, it projects to all these areas and causes all the effects that we were talking about earlier in our slides. And then the next slide is just a further breakdown, and it's more of a colored breakdown of in the brain of all the projections of, again, we're talking about projections from the ventral tegmental area. So you'll see that most of these arrows, or actually all these arrows, originate in the area of the ventral tegmental system, and then where they project to and all the areas that this can control in the brain. So that's why opiates are such a problem for patients, because once you affect that dopaminergic system and it can project to all these areas in the brain, you can see by projecting to all these areas what kind of major issues it can cause down the road if it becomes a problem, if overuse of these drugs becomes a problem. So moving on to the next area, talking about dopamine receptors. So there's 5 different receptor sites for dopamines, as well as the dopamine transporter, or DAT. And studies have shown that different dopamine receptors have different roles in addiction. The mu opiate receptors are the ones that we talk about more because that's where more action of these drugs are and where we see the dopamine release come from. But the dopamine transporter is a target for many drugs, cocaine being one of the most common. So if we can affect how dopamine is transported in the brain, for example, if I can upregulate the transport of dopamine, I can increase the euphoria that a patient feels when they're using. And we know that there's been multiple studies over the years that show that dopamine reinforces the rewards of drug use. And future drug targets have actually been theorized targeting specifically dopamine receptors. Each one has a different effect in the role of addiction. So what are some different dopamine receptors? What is the role of dopamine receptors in addiction? So on the next slide, studies involving knockout receptors in mice have been used to characterize these receptors. So D1 receptors enforce the reward of consuming alcohol. So when you knock out the D1 receptor in a mouse, they don't get that reward system that you have when you use alcohol. D2 receptors show a preference for alcohol consumption. So again, you knock out that receptor, those mice don't have a preference to drink alcohol. And D3 receptors don't show much difference except in the role of drug-seeking behavior or relapse of addiction. So there's a couple of studies I've looked at that have looked at D3 receptor knockout in mice that have shown that mice that have their D3 receptor knocked out specifically don't have the same drug-seeking behaviors or relapse potential as mice that have an active D3 receptor. So that's an exciting drug target in my area when I think about it, because if we can affect a D3 receptor, we may be able to help patients along the way even more than we can now, because if we can stop drug-seeking behavior or relapse, we're going to help these patients be more successful down the road in maintaining recovery. So I talked about, on the next slide, I talked about cocaine a little earlier and its effect on dopamine transport. So the next slide shows just how drugs can increase dopamine. So just a picture of, you have dopamine release when you eat something you really enjoy, but it's mild. So you can see the dopamine transporters. You can see the little orange balls that represent dopamine, and are the little orange balls that represent the dopamine transporters. And you can see what happens when you eat something you really enjoy. There is a release of dopamine, and your brain says, "Oh, I really enjoyed that. I want to have that again." Versus the next one that shows while using cocaine, it's an overload system. Your dopamine transporters are upregulated to the point that your body doesn't know what to do with all of it. And it's a magnified euphoric effect. So then you see that and your body's like, "Oh, we really like that." And it lays down an even heavier memory of, we did that and it felt really good. So the next area we talk about endogenous and exogenous opiates. So endogenous opiates are the endorphins, and they were discovered in the 1970s. They function similar to morphine and give analgesia and mood elevation. So when you get hurt, your body tries to control the pain itself by releasing these endogenous opiates or endorphins. When they're produced, the body also releases dopamine and inhibits GABA production, which are, we've talked about dopamine. GABA production, or GABA, is another neurotransmitter in the brain that we talk about a little bit. It's a inhibitory neurotransmitter. So by inhibiting GABA production, it's allowing other neurotransmitters to be as fully active as possible because they're not being inhibited. And these endorphins bind to receptors in the limbic system, producing the above effects we talked about. So one example of this is a runner's high, or the phenomenon of an adrenaline rush after being seriously injured. So you'll see patients with very life-threatening injuries, patients that maybe are involved in a car wreck or something, crawl out of the car and walk and be okay because they have adrenaline pumping through their body. But when things start to settle down, the effects of the wreck become more and more apparent because the patient's succumbing to what's actually going on and their body's not compensating for it. And then when we talk about exogenous opiates, so this would be medications, they bind to those same receptors. And long-term use of exogenous opiates actually leads to a downregulation of the body's response over time to the exogenous, the body's production of endogenous opiates over time. So the longer and longer you use external stimulants, your body doesn't have the same response if you were to get hurt or anything, because it's relying on you to provide that response versus your body doing it. The next slide is just kind of an overview of when you have pain in your body, what happens to it. So you have a pain stimulus, it reacts with your spinal cord, it sends a signal to your brain saying, "Hey, we're hurt." Your brain responds to it by releasing those endogenous opiates. So this same pathway happens, but we block some of these pathways with drugs, and we try to control the pain so our body doesn't respond to it as much. So talking about opiate receptors. So opiate receptors is where a lot of these drugs exert their pharmacological action. So we have mu, kappa, and delta opiate receptors. When we're talking about these, they're the opiate receptors in the brain that are activated by a family of endogenous peptides, such as endorphins that we talked about earlier. There's other ones called enkephalins and dynorphins, but the one that most people are familiar with are endorphins. And like I said earlier, these receptors are also activated by the exogenous opiates, i.e. morphine would be one. And the main opiate receptors involved in these reactions are the mu opiate receptors and the MOR opiate receptors. So delta and kappa receptors that I mentioned, they play a role in combating addiction, and they're actually potential treatment options for addiction. So the next slide goes further into the opiate receptor subtypes. So the MOR or mu opiate receptors, they're what most people know and most people are familiar with when we talk about addiction. So they provide the analgesia, the euphoria, the physical dependence, the sedation, the respiratory depression, all the things that everybody associates with opiates. The majority of that comes from your mu opiate receptors. Your delta opiate receptors, they provide some analgesia, but the interesting thing about them is they actually inhibit dopamine. So if we can make a drug that targeted both mu opiate receptors and gave the analgesic effect, but also targeted maybe the delta opiate receptors, we can block that dopamine response. Kappa receptors, they actually cause analgesia, again, dysphoria, and diuresis. So again, if we can make a drug that gave you the pain relief, but it caused dysphoria, it wouldn't want you to use it. That's not necessarily as pleasant of a target as maybe just targeting a delta opiate receptor where it inhibits dopamine, but it's a potential target for helping with addiction. There's another subtype of receptors that there's not a ton of research on, or I haven't seen a ton of research on it. There's an OLR1 opiate-like receptor gene or subtype. It's responsible for analgesia, food intake, anxiolytic, and decreased withdrawal. So the thing about this receptor that makes it interesting is specifically that last part, the decreased withdrawal. There's not a ton of research into it yet, so I don't really want to speak on it as much, but it's an interesting target for potential drugs in the future. The next slide just kind of shows like drug interactions with the receptor. So what happens when you take a drug? If you take a drug that's neutral, your response stays at 0. So a cholesterol medication doesn't really give your body any kind of response for a reward pathway, so it stays neutral. If you take a partial agonist, which is a drug that just partially activates the receptors, you get somewhat of a response, but not the full response that you get from a full agonist. So if you give a full agonist, a full-on opiate, you see that you get the 100% response, and it goes up, over time to reach that full response. There's also inverse agonists that cause a negative response. We don't talk about those as much, where people are more familiar with the partial and full agonist. So what role do opiates really play in addiction overall? So again, we do a lot of studies in mice. So genetically modified mice, they studied morphine's analgesic and addictive properties were absent in mice that had no mu opiate receptors. So they can go in a mice's brain and selectively take out these receptors and see kind of what their response is. So what did these mice show? They didn't get the morphine-induced analgesia reward or dependence. They actually had increased responses to painful stimuli, reduced rewards to non-opiate substances, alcohol, cannabinoids, and nicotine. They didn't really have a response to those very much, and they had altered emotional responses. So by taking out these mu opiate receptors, we can see what a role they can play in addiction, because mice lacking these receptors had all these negative side effects from it, or all these negative responses to it. There's another type of receptor that we talk about on this next slide called the group 2 metabotropic glutamate receptor. They're MGL2/3. So there's two types of receptors. There's an ionotropic and a metabotropic, the MGLU. So these group 2 receptors are widely expressed in brain regions that are relevant to drug-related behaviors. They inhibit glutamate release, decreasing the reward behaviors with drug use. So if these receptors are decreasing the rewarding behaviors of drug use, they're a potential drug target in the future. So preclinical models of these receptors have shown to regulate both reward processing and drug seeking. So in my area and in scientific areas, that's exciting because if we can target these and help patients regulate their reward processing and drug seeking, we can potentially help them down the road to be more successful in their recovery. The next slide talks more about it, but they appear to control dopamine and glutamate release in addiction-related parts of the brain. So again, if we can control the release and the response of these medications, i.e., if we can develop an opiate that can provide the pain relief but also modify the dopamine response and the euphoric events, we can be a lot more successful in helping these patients, maybe maintain pain control without having the addictive side effects. All this research has shown that this receptor is emerging as a new therapeutic target for reducing relapse and drug addiction. I haven't seen any research on drugs specifically that are in development for this because it's still in a very early phase of realizing what this can do and how they can be effective. And lastly, just kind of drugs of abuse and receptor targets, just kind of going back over, what we covered. So opioids mimic our endogenous effects of endorphins at mu opiate receptors. They reiterate feelings of euphoria, modulate our appetite, and stress reduction. Cocaine, we talked about, enhances the effects of dopamine itself, resulting in reward. So back to that slide of talking about when you eat something, you have a really good response. If you use cocaine, that response is magnified. Benzos, when we talk about those, they facilitate the function of GABA, so they lead to a reduction in anxiety. And then alcohol facilitates the activation of a particular receptor for GABA. It's a GABA-A receptor, which is a subreceptor of GABA, and it inhibits function of the NMDA receptor, which is related to the intoxicating effects of alcohol. And I believe that is all I have for you guys. So Sherry, I will turn it back over to you now.
Thanks, Brett. I think Sherry's working on changing over the slide decks, and we're going to transition to our next speaker in just a moment. So Amanda, if you'll share your screen.
Hi, everybody. Can you hear me?
Yes, we can.
Okay, great. So I am Amanda Bullard. I'm the Director of Nursing at Bradford Health Services in Warrior. I'm going to tell you a little bit about myself. There's my cute little family. There we are. And so I'll tell you a little bit about me. I've been an RN since 2005. I have a little bit of experience in open heart, pediatrics, and home health, but I really came to find my niche in addiction treatment when I started with Bradford in 2009. I'm also an adjunct faculty in the DNP program at JSU, and my graduate studies, when I went through my graduate program for my master's and doctoral program there, really focused on substance use disorder patients, and particularly a concentration in OUD and MAT. When I started with Bradford, we were primarily an abstinence-based treatment facility. And we did utilize Suboxone for detox, but we didn't really utilize it much for long-term medication-assisted treatment. So we were primarily abstinence-based, and we were looking at, we weren't having great outcomes with our opiate clients. And so when we got to looking at why that is, and a lot of the science behind how to better treat our patients with opiate use disorder, we really got to focusing in on what the science said, and all of the evidence pointed to MAT. And so we really started looking into that, and we found out that there really is a lot of evidence to back up using that and how effective that is with our patient population. So we're going to share a little bit about how, what we found in our research there, and a lot of what I came to learn through, really bearing down and studying in that. Also during my time at Bradford, I have instituted a nursing clinical rotation because, just like the pharmacy students that Brett was telling you about, we really in nursing school do not get any kind of introduction to addiction treatment. So we really don't get to learn a lot about how addiction affects patients. Their nursing school is focused on teaching you how to pass NCLEX, how to get your license. But they don't tell you a lot about what you're going to see when you get out in practice, and you're going to see our patients in any practice. And so it's really important, I feel like that they get to see that, and all of the students really enjoy coming to see our patients and learning from us. And they often ask to come back again throughout their nursing school time. I am also a fellow of the International Academy of Addictions Nursing. I'm an active member of INSA, which is the International Nursing Society on Addiction, and I'm on the Health Policy Committee, and I'm also a Journal of Addictions Nursing peer reviewer. Also, I have played piano since I was 7, and I play every Sunday at my church. On the next slide. So what exactly are opiates and the opioids? I'm glad Brett kind of went into most of that earlier, but basically they're mostly pain medicines, right? So we see a lot of that. If you're given something for pain, particularly, I find that most people receive their first opiate generally for something from the dentist. Especially when I talk to some of our patients at work, they'll say, well, my first use of it was when I had a tooth pulled, or I had, my wisdom teeth cut out, or whatever, or it might be a surgical procedure or something like that. So here are some commonly abused opioids that you might see. On the top of that list right there is OxyContin. We're going to talk a little bit more about OxyContin in a little bit, but you might see the street names there in that third column. You'll see that's commonly what they're called on the street and how they might be used. Not always are they swallowed. They could be crushed up, snorted, injected. Our patients are very, they come up with creative ways to use things. Okay, on the next slide. So we're going to talk a little bit about statistics before we get a little more into it. Opiate overdose is the #1 cause of preventable death in the US. So it's one of the things that we could prevent, and we've made some great strides, really. There's a few really great things that have come out of the opiate epidemic that we can talk about as we get a little closer to the end of the presentation, but it's the #1 cause of preventable death in the US. The sale of prescription opioids and the number of opiate overdose deaths have both quadrupled since 1999. And you can see just here on to the right, the graph that shows you. So the blue lines are the overdose deaths by any opioid from 1999 to 2017. And then male and female are the 2 lines in the middle. And then when you click it to the next slide, Sherry, it'll kind of show you our rankings in the states with sales. So as you see down here in the Southeast, where I'm not sure where all you guys are located, but where we are in Alabama, we're kind of higher ranking up there where we have a good bit of opioid sales. So, okay, to the next. So this is our national drug overdose deaths, but I wanted you to see this slide because 78 people die every day from opiate-related overdose. And like I said, those overdose deaths have increased 200% just since the year 2000. If you notice, these first 3 lines are all 3 of those overdose deaths. Those 3 lines are opioid related. So you have synthetic narcotics other than methadone, so primarily fentanyl. Prescription opioids is the next highest, and then heroin is the 3rd highest. So out of all of these, all overdose deaths for the past, 18 years that this covers, the top 3 are opiates. So it's really killing a lot of people. The way this epidemic is really killing a lot of people. On the next slide, please. And then this is all drug overdose deaths involving prescriptions. Some are involving synthetics, and then some without synthetics. So you can see that the blue is all the prescription opioids. The light yellow line is without synthetic narcotics, and the dark yellow line is with other synthetic narcotics. So as the fentanyl has started to come up, then the the other like non-synthetics are starting to decrease. So they're starting to use more fentanyl, which is more potent. Okay, the next slide. Just a few more statistics. Another idea, as you can see, we jumped up there in 2017, where we're using more synthetic opioids, more deaths. Heroin's kind of evened out, but prescriptions and synthetics are jumping up there. Okay. So 2 million people are dependent on or misuse their prescriptions. 1,000 people report to the ER every day. And one of the most, I guess, startling statistics that I've ever heard is that, the United States comprises 5% of the global population, 5% of the people in the world, but we consume 80% of the world's opioids. So, that's just we're a culture of excess, a culture that consumes the majority of the opioids in the world. So that's a lot. Okay, on the next. So we're going to talk a little bit about the history of it. In 1775, that's when opium first came to the U.S. It was started originally to be used to treat the soldiers of the Civil War when they started getting morphine for pain, and then they became addicted. There was this sharp rise in addiction, and it actually became available over the counter. They were selling heroin for pain relief and coughs. Now which has decreased a good bit now, but there still is a codeine cough syrup. So, clearly it works for coughs. And then in the early 1900s, morphine and pain management was pretty common. They started crushing their opiates and inhaling them strictly for recreational use. The Harrison Narcotics Act made the opiates available by prescription only, and that was back in 1914. And that was hopefully to limit the recreational use. On the next slide. And from the 20s to the 50s, they decided, well, and we're going to try to, control this addiction that we're seeing in all of our, population. So we're going to only prescribe it to people that are dying or in, really severe acute pain, and not do chronic pain. We're not going to treat chronic pain with opiates. And that was back in 1920 to 1950. So 50 years ago, we decided that this did not work for chronic pain because we were seeing that it was ineffective. It was not a good way to treat chronic pain because we were seeing addiction more than we were seeing pain control. So I want you to remember that as we continue to go through here, because we decided 50 years ago that this was a bad idea. So in the early 1970s, there's strong stigmas. Everybody's worried about getting addicted. The doctors they're deciding we're going to take other non-pharmaceutical methods to treat pain. We're going to try other things and not just give opiates to everybody. And then, the American Pain Society came around, and they are saying, we really need to work on non-addictive treatment for cancer-related pain. And then we started making other medications, Percocet, Vicodin, approved by the FDA in the 1970s and 80s. And then the WHO creates guidelines for treating cancer pain, recommending that opiates are used only if there's no other options available. That was in 1986. Okay, the next slide. But in 1998, Purdue Pharma spent millions of dollars to market OxyContin. I remember the first time that I heard of OxyContin, and that, I really first heard about it in cancer patients. And when I started nursing school, it was really more about, I remember thinking, okay, it's extended release. It's really more for, the really sick patients. They have to have it if they're, in severe pain. It's not really for, non-severe pain. So that's kind of how we learned about OxyContin. And then as, I started my nursing practice, I realized that a lot more people were getting it than just these severe pain patients. So morphine prescriptions, and from 1997 to 2002, a lot of people were getting more and more prescriptions for lots of other opiates than just, OxyContin or oxycodone or anything else. Morphine prescriptions increased by 73%, hydromorphone increased by 96%, fentanyl prescriptions increased by 226%, and oxycodone prescriptions increased by 402%. In 2001, medical centers are required to examine their patients' pain levels. So you might remember going into, prior to the early 2000s, going into your doctor's office, they may not have asked you, are you having any pain? Because generally you can look at somebody and generally tell if they're hurting or not by the way that they are presenting themselves. But there are other people that are in pain every day, and that's their normal. They learn to live with a little bit of pain every day because that's their medical condition. So maybe they don't report it to you. So the goal of this was to make sure that people who live in pain every day are not in pain that's not tolerable for them, that they're living at a tolerable level for them. And so that's kind of what the intent of that assessment was to make sure that it's not an excessive pain. And what it turned into is, like people that do not live in pain every day are getting asked, what's your pain level? Well, most people would say 0. A lot of people, though, were finding an excuse to be able to say, oh, my pain's a 5, even if it's not, because they knew if they reported their pain, they would be able to get something for it. In the mid-2000s, teens started reporting that they were using opioids that were found in their parents' medication cabinets. And then in 2010, people started moving from pills to heroin. Okay, Sherry, on the next one. In 2013, we had a spike of 27,000 drug-dependent babies born. And so they were experiencing neonatal abstinence syndrome, which is really horrific. I remember on one of my nursing rotations in the NICU to witness, babies having to go through that. It's really sad to watch. They really do struggle through all of that. In 2015, we have reached a national record of overdose deaths of 52,404. In 2016, the Surgeon General warns about announces that addiction is not a moral failing or a character flaw. It is a chronic disease of the brain that we have to treat like we would any other chronic illness. And then as of today, or when this graphic was produced, there are 142 deaths per day in the United States. So every 3 weeks, we have a loss that's equivalent to the loss that we had on 9/11, strictly from opiate overdoses. And so that may, of course, now with the COVID pandemic, that may have changed, of course. But so how did we get here? We'll talk a little bit about Purdue Pharma and their role, because they really were a catalyst in this. And since then, they have had some consequences to their actions. I believe it was last year or the year before. I know Brett can talk a little bit more about that in the panel discussion, but if y'all have questions specifically about that, but they had some consequences to the trial that they went through. But they introduced OxyContin to the market in '96. They aggressively marketed it, and their sales grew from 48 million to 1.1 billion in a matter of 4 years. They marketed it for non-cancer pain. They downplayed the addiction potential, stating that it could be given for acute pain, that it was not necessarily addictive because you were giving it for pain, you weren't giving it for something else. So they really just did not act like it was a big deal to give it to anybody. The regulations were limited, the FDA's oversight for the marketing and promotion of controlled drugs. And then it had become the leading drug of abuse by 2004. And there were several randomized double-blind studies conducted to compare how effective it was for OxyContin compared to other available opiates. And it was found to have no advantage over appropriate doses of other available opiates for pain control. So that showed that the success of OxyContin was not dependent on the merits of the drug itself, which really shows that it was really more about they just wanted to sell their drug. It really wasn't about, it really was the best for the job. It really was just about selling their medicine. So prior to the studies, the medical review officer concluded that there was no significant advantage compared to what was already available, which was the immediate release as opposed to the extended release. All right. How did we get here? Pain is what the patient says it is. So we talk about that. I know we talked about it a lot in nursing school. I think it's really taken out of context from its original intent. And y'all may have heard this in whatever capacity that you went to your you know, to get your degrees or licenses or whatever. But we learned, you know, pain is what the patient says it is. I think the context is I experience pain differently from you. You know, I think that's really what the intent was. It wasn't really meant to be, I'm actually a 0, I'm not in pain right now. But if I tell you I'm a 5, you have to believe me. I don't think that's the intent. But it was, I think it was taken out of context because of our culture of excess. You know, people find out that you can say anything that you want and get a pill for it. And if I say it's not enough, I'll get more. And so that's kind of how it's kind of grown from there. And then we had some physician prescribing practices. They overprescribed opiate medications, which, you know, when we talked earlier about how they had tenfold prescribing of OxyContin, they had, you know, over 400% increase their prescriptions of OxyContin and 200% increase their prescriptions of fentanyl. So overprescribing of those due to decreased regulations and aggressive marketing, because the whole goal was to better manage pain. So everybody's, you know, got this push to better manage pain, and they really kind of lost sight of, are they really even in pain? So on the next slide, there's also a stigma, which again, we talked a little bit about it, that really addiction, as we saw in 2016, it was really when it was first starting to be accepted as a true disease of the brain. And Brett's presentation just showed, you know, all the science truly backs up everything that it does to the brain. And in the brain, it really is a disease. It is not just a moral failing. It makes all these chemical changes, and people really don't understand that. It's always been accepted as a character defect, and it continues to carry a negative stigma. But people just really don't understand how it really does affect the brain, and it affects your actions and your behavior. So while it is a disease, the symptoms are just different. You know, if I have diabetes and my sugar is too high, I'm going to have physical symptoms. But when I have the disease of addiction, and I'm in, you know, a relapse, then my symptoms are behavioral. I'm going to steal from you. I'm going to take things. I'm going to lie to you. I'm going to not come around you, or maybe I'm going to snap at you or be ugly to you. I'm going to, you know, miss out on family gatherings. I'm going to do things that might hurt your feelings. And that's a lot less accepted than, you know, a person who has cardiac issues and is having a heart attack, because their symptoms are primarily physical, whereas a person with addiction, their symptoms are behavioral, and they tend to affect other people, maybe even more so than myself. So opiates are easily addictive. People with OUD are difficult to treat and have the highest recidivism. And we say that because they really do have a difficult time because of how vastly their brain is affected. They have a difficult time with relapse. So, which is why we'll get into why MAT is so important. So it's much easier to become addicted than it is to achieve recovery. Patients will begin using more to feel normal or attempt to achieve the same effect, because you get that tolerance, and tolerance and withdrawal and all those things kind of carry into actually even diagnosing opiate use disorder. So it results in extreme craving, which is why most patients relapse regardless of their recovery time. You know, patients with opiate withdrawal will not die from the withdrawal, but they will feel like they are going to. They're probably our sickest physically, but like as far as like their symptoms, sometimes they do tend to be more physically ill. But they're safer in their withdrawal because they're not going to die from it. You know, an alcoholic might literally die from withdrawal, whereas an opiate patient will not, but they feel like they're going to. And that's why a lot of times they will relapse. On the next slide, please. So prescriptions, they're doctor shopping. So if for some reason my doctor decides, you know, or only gives me a certain amount of pills, or I use up all the ones my doctor gave me, I might go to a doctor down the street and get another prescription. So they want to obtain more narcotics because what they have right now is not enough. 91% of individuals who survived an opiate overdose will go to the same doctor and get another prescription for more opiates from the same doctor. So that's an issue in itself. Maybe the doctor didn't know they had an overdose, which is another issue. There's no communication there. Or they're turning a blind eye, knowing that if I don't give it to her, she'll just go get it from somebody else, and maybe she'll get more, or she'll have, even more, a bigger dose or something, so there's always excuses, or, considerations from some physicians. And so, for why they decide to give their patients more opiates even after they've had an overdose. When really, now there's been a push for more education that these patients should really be referred to treatment, because they clearly, cannot manage their opiates on their own, or maybe they really do have an OUD. And then there's poor communication between each provider and pharmacy. There's not really been a nationally mandated participation in the narcotics database, especially for your small town pharmacies. They may not even have, there's one pharmacy that we work with that doesn't even have like a computer. So, there's just not everybody has access to the same technology. And so many databases only catch medications paid for by the insurance carrier also. So you may not catch things that are paid for with cash. Okay, on the next slide. So how do we assess if they need treatment or not? And this is particularly important also for your, like your primary care offices, or like your urgent care offices. Okay. There's going to be several assessments that a patient would go through. Obviously, a medical history, a psych history, substance use and treatment history. If they've ever been to treatment in any capacity, like intensive outpatient, anything like that, were they successful? How long did they have any kind of sobriety or recovery afterward? Or did they even finish it? Did they leave before it was finished? And then there'll be some sort of family evaluation. Do you have familial support? Do you have psychosocial support? Are you in this, on your own? And then what's the current use? What are they using? How much, how often, how long have they been using it, and how are they using it? And another thing to consider is, how are they obtaining it? Because, are you getting it from a doctor? Are you getting it from, your cousin's medicine cabinet, the guy in the alley? Are you getting it from, somebody's truck? You found it in, how are you obtaining it? Because that in itself could be a diagnostic factor for OUD. Have you had any attempts to stop using? So if you've tried on your own but have been unsuccessful, or do you not want to stop because you don't feel like you need to? Are you having any tolerance and withdrawal? So is the dose that you're currently at not enough? Or when you don't take it, do you feel, bad? Are you having withdrawal symptoms? And are there safety issues related to your use? So are you putting yourself in danger to obtain it? Or are you using despite having negative consequences? All of these things are things that we would want to see when we're assessing a patient and to determine if they have OUD. On the next slide. Another thing that we would look at would be the PDMP. So this is to access to detect if there's unreported use of controlled substances. So if you suspect that someone is maybe not telling you the truth, or if you're, like an OTP is required to access the PDMP, this is not something that's part of the medical record, but it is something that you may or may not be required to access. Like I said, some treatment providers are required to, and it's really just to see, what else they may be using. If you have a patient that is on opiates, it's really dangerous for them also to be using benzodiazepines, because the combination of the two is really can be considered fatal. That's probably the most dangerous combination is opiates and benzos for overdoses that we have found, at least in our patient population. So so for overdose potential. On the next slide. The PDMP, and since Brett's the pharmacist, if you have questions about the PDMP, I will defer those to him during panel. But basically the scores range from 0 to 999, and it represents a relative scoring system of controlled substance usage. So they are for 3 different drug types: narcotics, sedatives, and stimulants, based on the number of providers, pharmacies, milligrams, and then overlapping prescriptions. And then the graphic on the right kind of explains how it works. So if you have one provider, one pharmacy, a small milligram and no overlapping, then your score may be 200. But if you have, 7 providers and 3 pharmacies and, multiple milligrams and 128 overlapping prescriptions, then your score may be 780. So that's kind of how that works. On the next slide. So if a patient is presenting to us and they're intoxicated from opiates, then we're going to notice a few things. So they could be euphoric, so they could be extremely happy. They might be even a little bit in psychosis, so they might be seeing things. They might have, that's a little more rare that they are in psychosis, but they could be. They may have some improved self-esteem. They may feel pretty good. A lot of times we do see that. They may even say, well, I just have more energy when I am using than when I'm not, because they have an increased amount of those brain chemicals when they're using versus when they're not. They may also be a little depressed because, at some point, no matter how much you use, your body just does not produce the chemicals. So, and they may have decreased motivation because maybe they're lethargic or sedated. They may have a decreased appetite. A lot of people, when they're using, they just don't think about food. They may be oversedated or drowsy and have pinpoint pupils, slurred speech. And if they're using IV, then obviously we're going to look for track marks. On the next slide, if they're in withdrawal, these are the things we're going to look for. They're likely going to be very anxious. So they're going to have some increased general anxiety. We'll notice that they might be tapping their foot or just be generally anxious, looking around or not being able to sit still, just like moving around. Sometimes they'll stand up and just sit down and stand up and sit down. They do that a good bit. They may be depressed again or irritable and decreased motivation as well, just because they don't want to do anything. They have increased sensitivity to sensory stimuli. I noticed in the chat someone mentioned having something like that, but especially pain. Even when we're checking their blood pressure, they will say that the blood pressure cuff is significantly painful. So the thing that they really don't tell you when they're prescribing all these opiates to you is that long-term use of opiates actually results in a rebound effect, and it can cause you to experience pain. So instead of actually helping your pain, it worsens it. And that's considered a rebound effect. So that long-term use will cause pain instead of help pain. And then when you're coming off of it and in withdrawal, you have that increased sensitivity, which literally even is something as simple as a blood pressure cuff can cause you to have significant pain. So just anything that touching anything can cause pain. There's increased heart rate and blood pressure, goose flesh skin, or chill bumps. And it could be hot outside. And then watery eyes or runny nose. So that is just because I know, Jayla, us too. We were wondering what happened too. Sorry about that, technical difficulties. Another symptom, physical symptoms of withdrawal would be watery eyes or runny nose. And that's called rhinorrhea, and that's just because it's part of the things when you don't have opiates sitting on the receptors anymore. That's one of the symptoms that happens. And then you might see sweating or yawning, which I thought was the strangest symptom, but it really is. And the patients do that a good bit, even though they may have slept all night long, they will still yawn. A really common one is bone aches and joint aches. They say that they really feel it. It's like that they can feel their bones, and that's, again, the increased sensitivity. Decreased appetite and restlessness, of course. Some of them do have a great deal of difficulty sleeping, especially if they've been abusing sleep aids or benzodiazepines, things like Xanax, which we do commonly see sometimes used together. They may have nausea, vomiting, diarrhea are pretty common, and then dilated pupils. So they may have the pupils in their eyes will be very big, and then tremors. Often they may be pretty shaky. Okay, the next slide. So OUD technically is defined as a problematic pattern of opioid use disorder or opioid use leading to clinically significant impairment or stress. So how do we decide if they have this? So lucky for us, we have some diagnostic criteria. We're going to talk about that on the next slide. Okay. The DSM-5 gives us diagnostic criteria for determining if someone has OUD. And it actually breaks it down into 3 different categories where you have mild, moderate, and severe. So it's pretty simple. The diagnostic criteria is over here on the right. If you end up checking 2 of these boxes, 2 to 3 of these boxes, you have mild. If you have 4 to 5 of these boxes or symptoms, you have moderate. And if you have 6 or more, then the client is severe. And you don't even have to have them today. If the patient has experienced them in the past 12 months, that's how you can determine if they meet criteria for opioid use disorder. So if the patient has had any of these things, you would just decide, does the patient have a craving or strong desire to use opioids? Have they had that in the past 12 months? If they have, then that's one checkbox. So you could see how there could easily be several people that you might come in contact with, or several patients that you might have talked to that would easily meet criteria for an opioid use disorder, especially like a mild, potentially, even if their primary drug of choice is something else. If they've had any of these symptoms in the past 12 months, they could easily be a mild opioid use disorder. The thing is, most individuals will likely be moderate or severe, and those are the moderate and severe clients are particularly the ones that we're focusing on when we're talking about medication-assisted treatment. So on the next slide. So I've identified that our client has OUD, but what are we supposed to do now? Like, how do we treat them now? On the next slide. Well, the science says we should use medication-assisted treatment. And so what is it? It's the use of medications with counseling and behavioral therapies to treat OUD and prevent opioid overdose. So that's our primary goal. We want to treat their condition and prevent overdose. Our medical director has said a million times, you can't treat dead. And I know that sounds kind of harsh, but it's true. If the patient doesn't survive, then they can't be treated. So number one, we have to help them survive. And so one of the ways that we can do that, one of the ways that's been proven most effective to do that is medication-assisted treatment. The next slide. So what are the goals of MAT? Really, number one is an individual recovery from OUD. And I say that because not everyone's recovery looks the same. And I think that is probably one of the biggest things that, in particular, I know a lot of our, especially our nursing staff, because a lot of our staff are in recovery. So, they may have a recovery that looks a little different from some of our patients. And you may have been exposed to other healthcare professionals that may have different, viewpoints of recovery too. So there may be some biases about MAT, and so maybe they just don't know enough about it. And so it takes a little bit to understand that not everyone's recovery looks the same. So that was really one of the things that we focused on when we were transitioning from an abstinence-based, philosophy to an overall, it's really more about an individual recovery. How can we treat this patient and get them to recovery that's right for them? And then improve survival. Like, we just got to get them to live, it might be harm reduction. That might be recovery for them, because overall they survived, they survived this disease that a lot of people don't survive. Relapse and overdose prevention. So if we can, do some relapse prevention and prevent them from overdosing again, then, that's a goal of MAT. And if we can do anything, if we can increase their time in treatment, then we've increased their sober time. We've increased their time in giving them more tools to combat this disease. And that's one of the things that MAT is really, really good at, is increasing time in treatment. Unlike any other form of treatment for OUD, unlike abstinence, unlike a lot of other like faith-based things and a lot of other non-medication assisted treatment therapies, MAT has plenty of evidence to support how it increases people's time in treatment better than any other form of treatment. So MAT really is great at increasing time in treatment, which again, the longer they're in treatment, the more likely they are to gain more tools to combat their disease. And that's really the goal. It doesn't have to be a specific type of treatment, just treatment, give them the tools that they need, whatever that looks like for them. It also decreases illicit opiate use and other criminal activity. So research shows that MAT reduces the risk of contracting infections. So think about that too. So if it's decreasing HIV, STDs, hepatitis C, and criminal activity in the community, then our tax dollars, can be used towards other things too. So it's, they're not going to jail. They're not going to clinics so much. They're, all that stuff is kind of taking a burden off of the community and protecting the individual. So there's a lot of really good things that come out of them not using illicit opiates when they're going to medication-assisted treatment. They're getting the therapy that they need, and they're, staying in treatment, and they're not putting the burden on the community. Increasing the ability to gain and maintain employment. It kind of gives them a reason to want to continue to go to treatment because now they have something to fight for. Gives them a lot of times, we find that patients that have something to go back to, a job, a home, a family, they're more motivated to complete their treatment versus someone who's lost everything. Why would they? Why would they want to do treatment? So giving them more time in treatment and the hope to, gain and maintain employment kind of gives them, another reason, another something else to fight for. And then improving birth outcomes among women with substance use disorders who are pregnant. So MAT, like we talked about earlier, how we had so many new births with neonatal abstinence syndrome. While you're still going to see some of that with MAT, it's not anything like the risks that they take when they're actively using illicit opiates. Okay, the next slide. So why MAT? It's the gold standard of treatment. It increases time in treatment. Gold standard means we have tons of evidence backing up that it works. Again, it increases time in treatment. Under federal law, patients have to receive counseling along with their medication, meaning I can't just give you meds and send you on your merry way. There has to be some form of counseling. There's lots of different forms of behavioral therapies, and certain clinics achieve it in certain ways. Not everybody's form of counseling looks the same. And I'm not saying that everyone receives the same caliber of counseling. I know there's different forms at different centers. Okay, so I know, I'm not saying that everything is amazing, okay? But they do have to receive some form of counseling along with their medication. And so it could look different at different places. But they also can receive different assessment and treatment services such as medical, vocational, educational. So some people, can help get it. They can help them get a job. They can help them if they want to go back to school. There's lots of other things that they could get at some of these clinics that they wouldn't be getting elsewhere. So there's lots of other services that they can get with those. All right, on the next slide. And again, it reduces the opiate overdose deaths. So in a study in Massachusetts from 2012 to 2014, they studied 17,568 adults with OUD. So compared to patients that didn't receive any form of MAT, so these are comparing to abstinent patients, 59% of patients that took methadone, or 59% of patients saw a reduction in opiate overdose deaths if they were taking methadone. So in other words, methadone patients had a 59% reduction in opiate overdoses versus patients that took buprenorphine had a 39% reduction in opiate overdose deaths. Whereas, compared to the abstinent patients. So 59% fewer deaths in methadone patients, 39% fewer deaths in buprenorphine patients over 12 months versus the abstinent patients. So that's a huge reduction in overdoses strictly from that one study there. Okay, the next slide. So this kind of explains a little bit of how your extended abstinence from illicit opiates is predictive of your sustained recovery. It takes a year of abstinence from illicit opiates before you can say less than half of individuals will relapse. So a year or more, 1 to 3 years, it takes 1 to 3 years for before less than half of people will relapse. So you're looking at, if you can get people to commit to at least 1 year in some kind of treatment, then you're giving about 50% of your patients a chance at achieving, at preventing relapse. So that's kind of what the studies are showing. You can get them to, and maybe they won't commit on day one, okay? We get our population. They're probably not going to commit on day one. But with medication-assisted treatment, you have a higher chance of getting them to, commit a little longer today, and then tomorrow commit a little longer. It increases their time in treatment. And so that's kind of the goal. After 5 years, they have an 86% chance of achieving longer term sobriety and recovery. So that's, an even higher chance. So that's kind of what we're looking for. So, and maybe they're on MAT all 5 years, who knows? Some of them may not be, some of them may be. It looks different for everybody. So it really is individual. It's whatever works for that individual, and that has to be something that's worked out between the counselor, the patient, and the prescriber to determine what's appropriate for that person. On the next slide. So what medications do we use for OUD? Well, we have methadone, which, so Bradford, full disclosure, Bradford does not use methadone. We are not a methadone clinic. We specifically only use buprenorphine products at our facilities. But methadone is an MAT for OUD. Buprenorphine, which is a partial agonist. I'll explain that in just a second. And there's two forms of buprenorphine that I'm going to talk about today, which is buprenorphine naloxone, which most people know as Suboxone, and then buprenorphine monotherapy, which is most commonly referred to as Subutex. Naltrexone, which is an antagonist. It comes in oral tablets or an extended release injectable, which is most commonly called Vivitrol. Okay, on the next slide. So this kind of explains how each of these medications work. So Brett already talked to you about the receptors in the brain, which kind of really helps understand how this works. So you have your empty mu receptor, your empty opioid receptor. Your full agonist, which is methadone, sits completely in that receptor, just like every other, full opioid, like OxyContin, methadone, heroin. It sits completely down in there, and it completely fits perfectly. Like Cinderella's shoe, it fits perfectly in there. And so it's going to sit in there. The difference is that it does not, while it does kind of provide some of those same, depending on the dose, you have to be careful with the dosage. It does kind of provide some of those same effects. It does not give the same type of high like a heroin or something else would do. So the good thing is that it prevents the withdrawal symptoms. It gets rid of the craving and things like that. And it's safe to use long term. The buprenorphine, as you can see, it doesn't fit exactly in there. It's a partial agonist. And so it does fill up the receptor. It's going to decrease your cravings. It's going to get rid of your withdrawal symptoms. But it's not going to, it generates a limited effect. So it's not going to fit as perfectly or give you the same effect that methadone would give you, but it is going to take away the withdrawal symptoms and prevent the cravings. And so what that does basically is, by doing that, it allows the individual to at least participate in treatment a little longer. So instead of them focusing on their withdrawal symptoms, they're able to focus on their group session. They're able to focus on what they're doing in treatment today. They're able to focus on learning their new coping skills. They're able to focus on what their counselor is saying to them in their individual session. So it allows them to focus on the here and now and not focus on, I feel so bad right now. So that's what the medication is doing for them while they're in treatment. The naltrexone is a complete antagonist. And you may have also heard of Narcan, which actually is basically another form of naltrexone. But so Narcan is what we give when you overdose on opiates, but it's really fast acting. And what it does is it basically just knocks all of the opiates off of the receptor, and that allows you to be able to, kind of reverse the overdose. So the way naltrexone acts is once a patient is completely detoxed from all of their opiates, then they're given naltrexone or Vivitrol, and that blocks the receptor. So it quiets the brain. It allows them to be able to focus on what's going on. It kind of decreases the cravings and things, but it doesn't allow anything to sit in that receptor because it's blocking it. Particularly the injectable Vivitrol, it does that for 28 days. It's a injectable that it's a pretty big injection that's given, and it slowly releases over 28 days, and it sits on those receptors for 28 days. And then, so if a person tries to take an opiate, it can't get in there because it's being blocked by the Vivitrol. So there's nothing that can get in there. And so even if they tried to take something, they would have to take a whole lot to be able to kick it off the receptor. So because of that, they have to wear an identification bracelet so that if they're in a wreck or something, then the medical professionals will know that they have to really medicate those patients appropriately to override the Vivitrol that they're taking. So naltrexone tablets, on the other hand, have to be given every day, but there's some issue with compliance, of course. You always worry about medications that have to be taken every day when you're talking about this patient population. So, that's kind of why the Vivitrol is most effective for someone that's going to go with naltrexone. But it has been proven. Essentially, if you can get them to where they can start the Vivitrol, it's as effective as Suboxone. A lot of people just don't make it to the point where they can start it because of the withdrawal symptoms. Okay, on the next slide. So this kind of goes over a little bit of the differences between agonist, partial agonist, antagonist, that kind of thing. I forgot to mention, let me just mention right quick, Suboxone. The reason that Suboxone is the combination therapy of buprenorphine and naloxone is because if a patient were to, say, melt down their Suboxone strip or crush up their Suboxone tablet, mix it up with water or whatever, and try to shoot it up, then the naltrexone that's in there then becomes activated and allows it to be to where they couldn't necessarily overdose on it if it's injected. That's the whole reason that the naltrexone is in there. Otherwise, it's really inactive and it doesn't really give them any effect from it. Okay, on the next slide. So methadone, a little bit. It is the MAT choice for pregnancy. The reason for that is because there's so much evidence supporting its efficacy and safety for that. It does end up resulting in a little bit worser, is that a word? A little bit of a worsening neonatal abstinence syndrome for the baby. But the thing is that it is so much safer for a mom that has a higher risk of relapse. So, if your mom is a higher risk of relapse, then it's really, they really need to be on methadone versus any other form of, versus the monotherapy of buprenorphine. So it's the MAT choice of pregnancy. It replaces the drug of abuse because it activates the same opioid receptors, which we talked about. And its bioavailability is between 60 and 70%, which means it works very well. It's a fat-soluble drug, which means it's rapidly absorbed and widely distributed into the tissue, and it continues its administration over time. So what that really means is you could have withdrawals from methadone for a very long time because it's stored in your fat tissues. And we have seen that to where a methadone patient could withdraw for, we might not be able to start them on any kind of withdrawal medication. Say if they're coming in because they've been abusing methadone and they're trying to come off of it because they don't want to take it any longer, they could withdraw from it for, weeks to months. So because it's stored up in the fats. So especially if they're on higher doses or abusing higher doses off of the street or something like that. So it can take a long time to withdraw from methadone specifically because of that. It has to be dispensed from a federally licensed clinic that's specifically used for MAT. But it has been shown to decrease the use of heroin, other illicit drugs, decrease the transmission of HIV, hepatitis B and C, reduce the criminal behavior, all those great things that we look for from MAT. And really, it's been shown to increase time in treatment. So like people that would normally die or not have functioning lives are able to do that strictly because they participate in their methadone clinic. So it improves their lives, and that's what we're looking for. For a lot of people, this is the only way they're able to live a functioning life, and so that's really what we're looking for. For a lot of people, harm reduction is the only way that they can live. So that's kind of one of the really great things about this is it's been proven to really improve people's lives. On the next slide. Buprenorphine, it can be prescribed or dispensed in a physician's office as long as they have their X waiver through the DEA. And so OTPs or opiate treatment programs, they're allowed to offer it, but they can only dispense the medication in treatment. It's not like they can, give you your buprenorphine to go. So it has a lower potential for abuse compared to methadone. And it's a partial agonist, so it does have a ceiling, meaning I can take, all my buprenorphine at once, but I have a ceiling effect, so I'm really not going to get any more than that out of it. And you still have the potential for respiratory depression, but it's lessened compared to other, compared to like methadone. It's most often given as buprenorphine naloxone, like I said, because you have that naloxone in there to prevent the potential for diversion. And when taken correctly, then the buprenorphine dominates and it prevents the withdrawal symptoms. And then if you alternate, or here it is, if you alter it, then the naloxone will will dominate and then cause instant withdrawals. So in other words, if they try to inject it, then the naloxone is going to be the most prominent aspect of the medication, and it's going to, instead of causing a high, it's going to cause them to go into immediate withdrawals. Okay, on the next slide. Naltrexone can be prescribed by any doctor. I'll be honest though, there's not a lot of doctors that know a lot about how to prescribe this medication for medication-assisted treatment. They really don't, and there's not a lot that understand how to prescribe it for the reasons that we do. So most of the time, you're only going to see this prescribed by addictionologists, people that treat addiction. It blocks the euphoric and sedative effects of opiate drugs. It binds to those opiate receptors. It reduces cravings, and there's no potential for abuse or diversion. But like I said, there is some compliance concerns. So anytime that we prescribe this to someone, we always encourage them to have an accountability partner. So in other words, if we're giving it to a patient because they're, we're waiting on their Vivitrol, or they're not going to be able to take the Vivitrol injection, or for whatever reason they don't want the Vivitrol injection, then we're going to tell them, hey, we want to make sure that you talk to your wife, or we're able to talk to your wife and say, or your husband or whoever, and say that, they're going to be the ones that's going to be with you when you take your naltrexone tablet every day, because someone needs to be an accountability partner with them, knowing that, that they're taking it every day. Over time, the patients will develop a reduced tolerance for their drug of choice, and it reduces the, however, if they do relapse when they're taking this, because they'll be opiate naive again, they could potentially have a fatal overdose, meaning, if they're on the naltrexone and then they relapse and start using again, especially if they start using at their same dose, then they're opiate naive, they could immediately die have a fatal overdose. So we do talk about that, especially when patients come in, that once they're opiate naive, the risk for relapse and fatal overdose is very, very high. And then we talked about how the naltrexone comes. So if a patient's going to take the Vivitrol, they have to be opiate free for 7 to 14 days. Otherwise, they're going to be knocked into immediate withdrawals. And then, like I said, the injection itself is good for 28 days. So once it's in there for a month. There's no getting it out. So we require all of our patients to be at least 10 days opiate free, or 10 days after their last dose of Suboxone before we start it. And so we found that to be kind of the safest way to give it, is wait about 10 days. On the next slide. So there's a few other solutions. So now that we've talked about, we've identified the OUD, we're going to start MAT because that's the gold standard. That's how, most people find success in their treatment. Of course, not everyone's going to agree to that. So obviously we honor their wishes. If they wish to not do any form of MAT, that's fine too. But we do let them know that's really how most people find success. But then how are we going to go forward? Where does our country go? So there's some solutions that people have suggested. physicians and patients working together to control and correct their prescribing practices. So obviously we talked earlier, 50 years ago, they found that it doesn't really work if you're giving opiates for chronic pain. There's a very small amount of people in the entire world that can take opiates for chronic pain and not abuse them and not become tolerant to them and not, have this addiction potential. It's a very, very small amount of people versus giving it for acute pain, which is really what its intent is for. It's very effective for acute pain, such as surgical pain, post-op pain. It's really meant, for something like that. And cancer pain versus non-cancer pain. Cancer pain is a legitimate reason for opiates. Cancer pain is severe. Non-cancer pain may not necessarily require it. There may be times that it's required, for trauma and things like that. But for things like, daily pain, it's really not an effective measure for or an effective treatment method for chronic daily non-cancer pain. And there's been actually several studies that have studied things like Tylenol and Motrin in combination for pain versus opiates. And there's really not been much difference between the two. And I find that very interesting. So that's something to also look at for future, that it doesn't always have to be treated with opiates, but I think a lot of the marketing that we've seen from our opiate companies lead us to believe that it does. So that's just something to consider. Implementation of take-back programs in pharmacies. I've seen a lot of these lately, especially near, like I said, I don't know where everybody's from, but I know when I go down toward the beach, like towards Gulf Shores and Orange Beach and things like that, there's lots of billboards that say, a pharmacy take back day or whatever. And you can, take it doesn't matter what prescriptions they are, whether they're opiates or not, but you can take them all to the pharmacy and they'll destroy them for you, which I think is really interesting. There's also now different, sometimes we go to conferences, there'll be pharmacy reps there or different kind of company reps there, and they will give us envelopes and you can put your narcotics in there and it's a way to destroy them. So I think that's really interesting. So there's lots of things that they've come up with so that you don't have your medication in your cabinets so that your kids can get a hold of them or your visitors to your house can find them. Integration of behavioral health and medical record and primary care medical record through a national IT program. Wouldn't that be fabulous? If we could all know what was going on with our patient throughout the whole time, to know their medical record and their behavioral health record, because they don't always share everything with us. And then change the culture of the population so that the negative stigma associated with addiction is removed, because it really is, like I said, a disease of the brain. And I think that again, really should be something that we're also teaching to our healthcare professional students. They really need to know that on the front end so that they're not coming into it already jaded from, people that really don't know much about what is really going on with our clients. Okay, on the next slide. Also, if you haven't checked out Healthy People 2030, we have new addiction objectives. So there's the website for that there, and it kind of goes over what they're hoping to do and what kind of things that they're planning to do to address our epidemics and things. Opiate prescribing practices, less is best, of course. We want to start out with, if you're going to have to prescribe an opiate, start out with the least most effective. And especially now, I think a lot of the dentists have just, like I said, originally, if you ask somebody, when's the first time you tried an opiate? Oh, it was at my dentist. My dentist gave it to me. Now, a lot of the times they're going to give you, Motrin, just like a prescription strength ibuprofen, or, something more along those lines instead of giving you opiates. I think is a great. Consider alternative forms of treatment for pain as first line. A lot of ERs are doing that now. I know there was one that a conference that I went to, and on the TV in one of the waiting areas, that was their advertisement, is that they do not treat pain with opiates as first line. So that was their advertising to their clientele, is that, hey, come see us, we're not going to give you opiates, which I thought was wonderful. And then knowing that pain isn't only what the patient says it is, there's lots of other things that we need to consider. You have subjective and objective data to determine appropriate treatment measures. It's not just what I say, but how I act. How am I presenting to you? What are my vital signs? What am I looking like? Again, a very small portion of adults function well with opiates for chronic pain, and it's just not the norm. And then closely assess patients for signs of dependence at each visit, which means that we're going to have to give prescribers the tools that they need in order to assess these patients and how to refer them to treatment when we suspect that there's abuse or misuse. Okay, on the next slide. And then removing the stigma, normalizing the treatment to know that these people our patients are not alone. It really can affect literally anyone. While it is very common among patients that live in poverty, it's not only those patients. You know, it can cross all barriers. It's not there. There is no one size fits all. So it really should be normalized. You know, the mental health treatment is becoming more and more normalized nowadays. And so, you know, the treatment of substance use disorders also should be. And like I said, more education among healthcare professionals. That was one of the biggest things that I think made a huge shift for us was when we did more and more education with our staff, and they started to see the value and how you know, our patients were responding, and how many our AMAs were decreasing among our opiate clients, and how they were transitioning to the next level of care. You know, I think that was really what made the difference for them, is seeing that it was really actually affecting how long they stayed in treatment. So I think that was, you know, just providing that education really helped them to understand why this does work. Educating providers on you know, screening, brief intervention and referral to treatment, or SBIRT. Informing community of the available resources, and just increasing time in treatment. If you don't get anything else out of what MAT does, know that it increases time in treatment. And if nothing else, that's what any client with addiction needs, is more time in treatment. And it doesn't, I'm not saying more time at Bradford, I'm saying more time in treatment, some form of treatment. So that's really what MAT is all about, is increasing time in treatment, and that's what it does for our clients. I think that might be my last slide. Yes, it is. So I'm going to turn it over to Zach.
Thank you very much, Amanda. Really enjoyed it. Apologize to everyone again for our technical problems, but we are in the home stretch, so fingers crossed. We'll go on to the next slide. We'll jump right in. A little bit about myself. I'm a licensed counselor in 3 states, Alabama, Tennessee, and Florida. I've been working at Bradford for about 10 years. I've had a few different roles. I started out working as a primary clinician working with adolescents, adults, and families in Tennessee. And I transitioned in a leadership role, working as a clinical coordinator for that clinic. And then since 2016, I've been here in Birmingham at our corporate location. And I've had a number of different roles. The majority of my time I've been working in clinical operations. So I'm working with our counselors who work, you know, in our residential and our outpatient facilities, hand in hand with our nurses and physicians, working on MAT initiatives as just part of that. And Amanda talked a little bit about our history with MAT as a corporation, as a provider. And so I've been able to see that through working as a counselor as well as in a leadership role. I do a lot of trainings, and I hope to see you all again in some of our future sessions. I hope you've seen some of the things we've done before, because these are the things I really like enjoying. I like speaking with you. I know we have a lot of diverse helpers on our call today, coming from all over, different backgrounds, different knowledge base about MAT. Hopefully you've gotten something from the training already today. I'm hoping now that I can speak to you from my vantage point as a counselor and someone who's helped navigate some people through making decisions about MAT and their treatment planning. Next slide, please. So, you know, we need to recognize that counseling as a role in therapy, you know, in behavioral health and substance abuse, you know, we're always going through waves and shifts. It wasn't all that long ago that mental health treatment and substance abuse treatment were very different camps, treated differently in regulation, treated differently in standards and in practice. And you know, those have merged together largely over the last 20 years or so, depending on other states you might be operating in. Maybe you were a little bit more progressive in that, but always a little bit behind the curve. And also therapy is typically behind the curve of medical advances. So MAT is a pretty good example of that. As we learn and understand more about substance use disorders and how brain mechanisms work, it becomes less abstract, much more concrete, and we need to be, addressing those issues. And so our role doesn't really change. When I think about why do people enter the field to be helpers, it's often to advocate, to help, to empower at an individual as well as a community level. Our goal should always be to improve functioning, reduce suffering. That comes in a lot of different views. How we do that. What does that really mean? Does that mean total abstinence? That's a little bit more of a old school way of thinking. Is it reducing recurrence of symptoms? And substance use is symptomology, often of other co-occurring issues going on. So if you start looking at it through that lens, we can be, in my opinion, much more receptive to the needs of our patients. And at the very core foundation of this is, what are the patient's goals? Last thing Amanda was talking about was bias and stigma, and I'm going to speak a little bit about that in the short time I have with you. But one thing we know is that even within the treatment community, there are biases about medication-assisted treatments, and that will influence often negatively our clients, and that is a major problem that creates ethical issues when we're not respecting the autonomy of our patients. And I also recognize as a provider that balancing recommendations and balancing autonomy can be very difficult at times, and there's often not a black or white solution. It's often more in the gray, and that can be difficult for some providers, and it can be difficult for some of our patients too. Next slide. Within the field of counseling, we need more emphasis of evidence-based practices, and that's getting better always, but some providers, some individual counselors in the world are less attuned at that and staying up to date on the latest research and the latest interventions. Now, when I say evidence-based treatments, I'm not meaning anything too radical. I'm talking about cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing, trauma-informed approaches, and the way that we then couple that with MAT. MAT does not have to be separate from the interventions we do as counselors, therapists, social workers. They should work hand in hand. These are just different tools all in one toolbox. And historically, one of the issues that's happened is there's been this segmentation. MAT especially, where even today, people can get medication to treat pain or treat opiate use disorders without getting counseling or without having any other support mechanisms in place. Now, there are protocols, there are regulations that say that those should be there. However, we all know that not every provider is on the up and up with that. And so that becomes a cultural problem with this, because that does create additional problems when there's these access points that exist that are in many ways doing more harm than good in a lot of cases. Modalities can seemingly be at odds. Treatment used to be based in more of the abstinence-only model, often referred to as the Minnesota model. This is something that has been around in treatment providers for the longest time. It was largely utilized NA and AA principles that relied on no use of mind or mood-altering chemicals. You kind of pivot that with some more realities of what happens in the world in our harm reduction models. And in harm reduction, one of the main principles of it is recognizing that licit and illicit use of substances is going to happen. We cannot police our way out of a substance use problem. We tried that for a number of years, didn't work. A lot of people are to this day incarcerated because of that. That is a world problem. That is a cultural problem. And instead of being punitive, penalizing people for a mental illness, we need to be being adaptive to solutions, recognizing that there is no perfect solution. MAT plays a major role in that. We as helpers with our counseling play a major role in that, in changing the paradigm. And when we incorporate psychosocial approaches in conjunction with the MAT, we recognize these are additive. They are both adding to the solution for that client, each contributing to that better response and the better efficacy of the services that they get. We know, and I think it's been mentioned, that substance use success from the treatment is comparable with other chronic conditions. You can make comparisons akin to diabetes. Let's keep that always in mind, and we know that long-term treatment is better, and the more engaged someone is with their treatment plan, the more successes they have. Other examples of that I think everybody can come to accept is we now know in the treatment world that detox only is not a viable solution towards long-term sobriety. If somebody goes through a detox protocol over a few days, even a couple of weeks, they do not have mind or mood altering chemicals in their body, in their brain, and then they go back out and they don't have the tools with which to face the world, they're likely to fall right back into the same patterns again. Same principle works with MAT. When people are stabilized on a medication, it is not the same as illicit drug use. That addresses, some of the concerns people have about replacing one for another. That's not how it works. We can challenge those ideas by really putting side by side the behaviors we see of people who are on a medication. When people are not on a medication and they're in their active use, what do we see? We see a disease that is often associated with denial that the disease is even there. We see behavioral consequences. We see relationship consequences, potentially financial employment consequences. When someone's on a medication, what do you have? You have stability, you have more transparency, and you have the ability to address those psychosocial stressors and improve one's function in life. Next slide. So a provider needs to know about these psychosocial strategies, addressing the entire person. And, I mentioned here psychosocial. It also includes the biopsychosocial. And I know Brett and Amanda kind of spoke a little bit more about the biology of it, but we need to take that into account, because somebody cannot get well if their basic biology is not being managed. If someone is uncomfortable because they are in withdrawals or because they are craving, they're not going to be able to work on those relationships or work on getting that more stable employment. You can think about this as, kind of Maslow's hierarchy of needs. And at the very foundation of it is just the physiology. And above that is the safety. And one thing that treatment and that MAT starts to provide is a stable physiology and a predictability about how we live in the world. Once that is taken care of, then the individual, with the help of a counselor, can start working on those other needs, the belongingness, the esteem, and hopefully the self-actualization at the very peak of the hierarchy of needs. But we have to start at the base. And these strategies, we largely can do a lot of education, and education is key. Educating patients. There's a lot of misunderstandings about the medications. Amanda gave a summary of those. Those summaries are beneficial to our patients to know the differences of the medications, how they're going to interact, how it's going to work short-term and long-term for them, so that they can make educated choices. Families need that information as well, because they have their misgivings, and they're often very similar to those of the patients, but they're also informed by the experiences that they've had watching their loved one struggle with their substance use disorder. When we address these needs, we can, just by doing that, increase compliance with the medication itself. And we can also, by incorporating some other behavioral interventions, which we're going to talk about very briefly today, we can promote abstinence and relapse prevention. Relapse prevention meaning compliance on a medication that is prescribed, and working a treatment plan guided for recovery. The provider, as a provider, you need to understand this basic information. You need to do your own due diligence on substance use disorders, diagnostic criteria, specifically opiate use disorder. What does it look like? How does it work? How do these medications work? Today you've attended and hopefully you've learned something from doing that. We pivot that information now into, well, how do we take that information and create a supportive environment that is guided in an individualized recovery journey for our patients, reconciling the goals that they have and their motivation for it, as well as their abilities to do it. And we're going to talk about that too. We have to recognize that we exist within a larger system. We are not islands to ourselves. When we are working with a client who is on medication, any medication really, but especially MAT, we now are part of a larger treatment team, and communication is key. Coordination with providers is key. So, like, luckily, working in an organization like Bradford, we are working hand in hand with an interdisciplinary team. If you're out there as an individual practice on your own, I encourage you to make connections with providers in the communities that can provide these medications. And if you are working with a patient who is on these medications, find out from them if they'll consent for you to coordinate with those prescribers they're already getting medications from. Many gains occur whenever we have transparency and communication. Next slide. One place you can start after this is please access free resources that are available. Here's just a couple of examples. You can Google these. The SAMHSA Tip 43, Tip 63. This talks about the MAT. It talks about overall treatment planning for people with opiate use disorder. You can download these PDFs for free. You can also have them mail you paper copies if you prefer. This plus so many other resources are out there, and it's on each of us as a provider to be aware of them. Next slide. Treatment planning. So every assessment should always include a substance use disorder history. Now, Amanda gave some information about what that really looks like in a treatment setting and how comprehensive that is. If you are a private practice practitioner, as I know many people who sign up for our continuing education sessions are, one of the failings that can happen, and I'm not calling anybody out, but we sometimes fail to do thorough histories. And that's because we're often presented with a specific crisis or problem from the client, and we usually start getting into it pretty early in the first session. And then it's as we dig, we start finding some of those precursors. You know, they're presenting with relationship problems with their spouse. When we get to it, they're fighting about financial problems. The individual is using drugs or is drinking, and that's creating these stressors. And that's not usually the first thing that they say when they are reaching out for help. That's not usually the first thing we hear about when people reach out to help, specifically as a substance use provider. So it's on us to ask the questions. This is part of our, SBIRT, the screening model. So I'll direct you towards a few things that you can look up, such as the CAGE questionnaire, and then specifically the CAGE-AID, which includes more information about non-alcohol substances. But the basic format of these is real quick. You ask somebody if they ever try to cut down on their use. Have people ever been annoyed because of their use? Have they ever felt guilty because of their use? And have they ever used a substance as a means of opening their eyes in the morning to get going? 2 answers of affirmative to those questions in a man is an indication that more digging needs to be done. That's a pretty significant finding. For women, it's a 1 positive for that screening. That's how quickly you can incorporate substance abuse screening in your practice. And there's lots of others like the CRAFT and the DAST and the TAPS, TAPS, because that includes tobacco, alcohol, prescription drugs, as well as other substances. So these are really brief screeners, good place to start. Once you've done your screening, once you've made some preliminary impressions and diagnoses, it's important to be sharing those with your client and incorporating what's that going to mean for their recommendations and their prognosis and treatment, and obtain feedback from them. One thing that I know is that when treating substance abuse and mental health, and they often do go hand in hand, it's chicken or the egg, but it's usually simultaneous presentation. If you don't get the drug and alcohol under control, treating their other conditions like depression, you're not going to get a lot of headway. Because the chemical impact is going to continue to affect the serotonin and the dopamine, and you're going to have an outside variable impacting their brain chemistry. So once we kind of make those alliances, we'll make the agreements of where we're going to start. How can we incorporate medication into that treatment plan? And that can be a number of the different medications we talked about. It could be things like the Vivitrol or naltrexone, which works very effectively with opiate use disorder, also as well as with alcohol use disorder, as well as the other options that are available. Next slide. Before you work with patients, you need to make sure you review your own biases about drug and alcohol use disorders themselves, about opiate use disorders specifically, and even more so about medications. We are all citizens of the world. It is very likely that you yourself, a member of your family or a close friend, have struggled with substance use disorders or are currently struggling. And what that does is it creates different ideas about what works and what doesn't. It is our ethical responsibility to bracket our personal beliefs as to reduce the chance that our beliefs could impact a client or their decision-making about their care. When we respect the dignity of a client to be able to make their own informed decisions, we are giving them that greatest respect we can give, which is the unconditional positive regard. We have to shift the paradigm and expectations about what treatment really looks like, because many clients are looking for short solutions. They want something that will work and work now. That's not how treatment really works. That's not really how life really works. Anything worthwhile is worth working on for the long term. So making sure that people understand that while medication certainly plays a role in addressing cravings and relapse risks and withdrawal management now, there are considerations down the line about what does the long-term plan look like. Not as a means of dissuading. There is no time limit on how long someone can choose to be on an MAT. What's important is thinking about, is this someone who's looking for that short-term plan so that in a year they can taper off? And that's fine. Let's just know that going in. Let's have that discussion, because depending on the medication, it might require some additional work. It's sometimes not easy to facilitate that taper plan without support. So we just have to know that. We'll go on to the next slide, please. This again spoke to some of the biases, and I'm not going to spend too much time on it, but I challenge the world. I challenge treatment providers especially to think about how our language impacts the clients we work with. The word addict even itself has come out of vogue a bit in treatment providers. And I know that that's not really aligned with the recovery community, because if you go to an NA or an AA meeting, people self-identify many times as an addict or alcoholic. Worser terms, which have no place in either setting, are words like junkie or fiend. I mean, these carry incredible bias. Just even saying them or reading them just doesn't feel right. But within the treatment community, even like I said, the word addict should be replaced with person with a substance use disorder. And because of our changing philosophies about this as a medical condition, we have to talk about it as such. And we change our language from addicted even to dependent. Becoming physically dependent on a substance is fairly easy to understand in my viewpoint about opiates. And I speak with people sometimes anecdotally, family members who really can start understanding how easily people can fall into the trappings of opiate use disorder because they themselves have received a medication following a surgery or dental procedure. They took it as prescribed for the days that they had to take it, a few days, maybe 5 to 7, something like that. And they stopped taking it and they say, oh, I felt a little bit weird like that. I didn't feel good. Like I was constipated a bit after, I had restlessness. I didn't sleep very well for a couple days. Is that what it's like if somebody stays on opiates long term? And the answer is yes, times 1,000. So I think that creates some greater understanding, but when we put it in the lens of dependency versus addiction, it carries less stigma. Lastly, one of those wordings about how we talk about positive versus negative, especially when we talk about drug screens as a treatment world, positive and negative is the proper vernacular. We don't say dirty or clean. That carries a bias. We don't think about people as dirty if they have a positive screening for a substance in their urine or breathalyzer. It's not a judgment. There's a lot of misinformation out there. I mentioned it a little bit, trading one addiction for another. Put them side by side, make a list. What were the characteristics of active use versus somebody stabilized on a medication? And there's usually a pretty stark contrast, especially for somebody that starts working other parts of their recovery, like doing counseling, being part of support groups, working on getting themselves well overall holistically. MAT, it's said, is a substitute for heroin. I hope from hearing some of the differences about the biology and how it fits into the brain, you see that while there are similarities in terms of receptor activation for some of the medications, it doesn't work quite the same way. The patient is still getting high is a kind of misinformation that's out there among patients, among families. Somebody who's stabilized on an appropriate dose of a medication should not be exhibiting the same symptoms you might see of them if they were actively using, like the nod, the slurred speech, the disengagement. Again, that's with stability. It's not a perfect science. There does have to be some adjustments to medication often made. Feedback from the patients often really helps with that. And then the last bit of misinformation here that someone is not really in recovery. There's lots that can be said about this, but we have to encourage our recovery and treatment communities to be receptive to being open to solutions, because we cannot work with somebody that has disengaged with treatment because they've gone back to active use because medications were not made available to them. That is a misstep as a treatment provider. Similarly, denying access to medications can result in dire consequences, including death. Again, a major misstep and preventable. And there are differences of opinion within recovery communities. Some are more accepting than others. Those waves, I think, are changing a lot as medication becomes more and more available and people understand it more. So that's all I'll say about that for now. If we'll move on to the next. I mentioned this a little bit, but I just want to reinforce it's our role as well to shift the paradigm, the view of a chronic versus acute care model. A lot of times substance use disorder was treated very acutely. One episode of care, even if it was 28 days and then done, that doesn't work anymore either. Even with shorter term interventions, as long as it's spread out over time, that's going to be the most responsive to a patient, because the thing is, a patient's needs change over time. We are often working with them in a very acute setting where they're needing that withdrawal, when they're in withdrawals and they're needing that detox. But in 2 months, that's not going to be the physical state. They're likely to be in a different place. They may have gone home from that residential or hospital treatment, very likely. And they'll be addressing new stressors. They'll be back at work. They'll be facing family challenges, financial challenges. And it'll be much different than how it was when they were at a residential or hospital setting. Next slide. So we're going to talk about some key ideas. In the couple minutes we have left, I'm going to try to move through fairly quickly. You will get copies of all of this, so if you miss something, you'll still have access to it. Next slide. The first concept on that list was skill building, and what we recognize is that substance use itself is influenced by an interaction of the physical symptomology, the withdrawals, how the person is thinking or feeling about the substance use, that self-efficacy, motivation to change, as well as emotional states, depression, anxiety, trauma. All of those are creating a constellation of impact. So what we want to do is we want to work on identifying trigger awareness at a basic level. So how can someone recognize when they are triggered, when they are compelled to wanting to use? That's trigger. How can they avoid those? How can they in the future build upon that avoidance to cope so that the impact of those triggers becomes less? And then that becomes an evaluative process that's kind of a feedback loop that happens. And there's a number of ways people can do it. One activity I love doing with folks is a diary, where they actually keep a track of, today at this time I was triggered, or I had a craving that seemingly came out of nowhere. Okay, did it come out of nowhere? What was going on? What was the situation? Where were you? What were you thinking about? Who were you with? How bad was the intensity of that craving or thought about using? And you scale that, like Likert scale, 0 to 100, 0 to 10, whatever it is. You set that with the patient. How long did it last? Usually chronicled in minutes, sometimes hours, but usually minutes. And then how was it that you were able to overcome it? Did you do something different? Did you change the setting? What worked? And then hopefully what you'll start seeing, if you get enough data points, you'll say, this strategy you used seems to be working out better because the duration is always less when you do this thing. Whatever that avoidance mechanism starts to be, whether that's I called my sponsor and I talked it out. And as soon as I started talking it out and I got that feedback and I remembered that, hey, I don't have to live like that anymore today, that helped me. And then guess what? I got back to it, and the cravings were less. That is something that is a valuable tool. I will say it works best with people that are pretty motivated and also have cognitive ability to do it. So if you're working with anybody that might not have the intellectual capabilities of writing things down, or inability to write or read, that's going to not be a great solution. Always within therapy, we're reviewing past use episodes as a way of understanding the narrative of the client. This is their story, and often the story has many negatives. When they use this bad thing happened, and okay, we don't want that bad thing to happen, so what are we going to do in the future? When we do that, we start making that relationship between what reinforces behavior and then what diminishes behavior. And this starts then kind of along a behavioralist approach, which is very good place to start with people, because people don't necessarily have to understand the root of why addiction exists. They just have to know, I don't want the outcome of that addiction to happen anymore. I don't want to get in trouble anymore. And that kind of reminds me how it was working with young people, especially, who would fight tooth and nail that drug use of whatever type was not a problem. Well, I'm not in the business of arguing. What is the problem then? Well, the problem is they were getting in trouble, or they got kicked out of school, or they were on probation. Okay, and they don't want that anymore. So what are they going to do different? And if we just build upon that, we're not talking about opinions anymore. We're just talking about behaviors. Next slide. I mentioned the diary, but kind of on a deeper level, here's an example of what they call the functional analysis. So looking at the actual patterns of behavior, and this then you move into strategies. So now that we learn some things, it's likely you're going to face a difficult situation, such as the loss of a loved one, the loss of a job, stress in the future. What are we going to do to address it? One thing that people in recovery talk about is recovery can really feel like changing everything in one's life, and that can be really scary. And it is. And the thing is, it's not just changing everything in your life. It's changing how you respond to everything in your life, and that's kind of to me more kind of the kicker of the whole thing. It's all about how we respond. Behaviors in itself are fairly predictable, just in the world. Cause and effect. Brett talked about the overwhelming chemical makeup that we get, when we ingest things like cocaine, which is incredibly stimulating from a neurochemical level. We get that with sugar. We got that with junk food. People, when it comes to predicting behaviors, that's why diets fail, because one thing is more appealing than the other. And that's why it's hard to quit smoking. That's why it's hard to stick to that diet, why it's hard to eat healthier foods. So we recognize that. We don't minimize that. That's all very real. We all, I think, struggle with that with one thing or another. What are we going to do to develop that plan, though, is the question. Next slide. And one place we start with that is, using the thought management. So we list the past negative consequences. I mentioned that on the last slide. Somewhat more of a challenging exercise is responding to the positive thoughts around the use, because we cannot deny that drugs and alcohol have a euphoric, short-term positive effect. And that's what often draws people, at least initially, into substance use. Now, often with opiates, at the end of the use, at kind of the culmination where it starts becoming most problematic, it's an aversion of the negatives when they're removed. So it's not wanting to go into withdrawals that keeps the perpetual use going. But we can all understand drugs and alcohol equal positive feelings in the brain, increase in mood. Again, not arguing that fact, can't take that away. That happened. But what we do is we try to learn to challenge that. And the way we do that is with possibly within that thought diary, because the person will say things like, I could really use a pick-me-up today. Whenever I was taking opiates, I got that boost of energy that got me going. Well, we dissect that, we evaluate that. Okay, well, have there been times when you've been able to get that engagement, get that drive going without the use of opiates? And we identify what was going on during those times, and we try to culminate, from those patterns what we can replicate. And then that creates a skill. And then when we have identified that skill, then the challenge is now how will we in the future use that effectively? Within this is a mindfulness. It's a mind activity where someone can actually live with a thought or an observation about their using, and it's just a thought. It doesn't. It can lose its power. It doesn't have that compelling trigger, urge, feeling of uncontrollability that it did during the acute use episode. And that takes time, that takes stability, and it also just takes somebody who's able to go there in their thought processes, because it does take some guidance, and guided meditation is a very effective strategy when trying to address that. Next slide. Okay, so thinking about reinforcements, so when a study poses two reinforcers that are competing with each other, and in one part of it substance use, and in one part of it another appealing reinforcer, money, food, we actually lessen the drive over to the substance use in experimental studies. And one thing we can gain from that, again, from the behavior, is reinforcing. And the Kraft model takes that reinforcement, moves it into a family system, which so much of recovery is based in families. So how can we educate, empower families to set realistic, natural consequences, as well as reinforce consequences that are within their household, like rules, expectations for loved ones? That can provide a lot of leverage in the therapy. I'm going to move on from that just because I'm noting the time. One of our jobs is to address ambivalence and change talk. So thinking about the stages of change, moving from a pre-contemplative state to an action, and then the goal being a maintenance phase where the action continues. Because we know that saying versus doing is often a pretty big contrast for people who are actively using. They say, I'm going to stop. The behavior tells me that that's not going to happen. That being said, though, it's interesting because someone verbally committing to staying sober, verbally committing to working the treatment program, actually does have a positive correlation with completion and recovery rates. And a lot of that's just accountability partners. I think we know that we are more accountable when we tell somebody, hey, I'm going to start my diet tomorrow. Hey, this is my last cigarette. And when we tell somebody, we've made it known, and that actually has a lot of impact here. And if you put that in with motivation and change talk, our goal is to work through some of the ambivalence. We want to be finding those reasons why that person wants to change. We want to wrap that in with their ability to make those changes, give them positive affirmations, and use our reflective listening to give them that mirror feedback. Next slide. And there's lots of examples. I'm not going to go over these because you can read them, and you'll have the slides available to you. All the questions we ask, all the reflections we give, perhaps the answer is, if you made a change today, what would be different? And a lot of times the answer is, I might get this thing back. I might get my family back. I might get my job back. Go one more. I might get this thing I want back, or I might have better health. Well, then we go to, well, in order to do that, what has to be different? Maybe the person says, I have to be stable. Medications provide that stability today. That is one viable option. So maybe that is the avenue for that person. Next. And we build the social support. We got to have social support in our treatment plan. One study said that 60 to 80% of individuals with a substance use disorder live with a family member or have regular contact with a parent or family member. That makes sense to me. That number reigns true based on what I see. We know that support helps with treatment engagement and outcomes. We know that in the short term, those family members can help with monitoring, medication compliance, can reinforce the plans with the medication. We improve communication. And then the self-help groups in the long term show good sobriety rates following what can be done with a treatment provider or with a counselor or social worker. It works differently, it works long-term, it provides something different that a therapist cannot always provide. Next. So when thinking about your involvement with family, please look at resources that are available. This is just one of them. It'll be available to you in your slides. Next. Dealing with family stressors. You know, when we take that model of the family reinforcement, we learn about positive communication. What is quality communication? We learn about how roles work within the family that might have kept that use going and what is going to sustain recovery. We help families with understanding about the substance use disorders and especially the opiate use disorders. We address those biases about medication, and we help to look out for signs of relapse and overdose, and we provide that education to the families about overdose medications, so that naloxone, because we know that those medications are more likely to save the life of the person in your proximity than your own life. And I'm talking about family members using them or someone using them on someone they are using with. Next. I mentioned earlier, as a provider, you're part of a bigger treatment team when medications are involved. Communicating with consent with that prescriber helps to go hand in hand with the progress being done in primary therapy as well as with medication compliance. That can help to have those discussions about medication choices, because patients themselves have different thoughts about their motivation level of being on medication or wanting to discontinue or not wanting to pursue it at all. And when we understand more of the medical side of it, always deferring to the medical provider for the prescribing decisions, but I get a better understanding of why someone can be appropriate for those medications. Why we're important as counselors is because we often largely will see the patients more than a nurse or a doctor or the prescriber. We can have a more complete sense of some of the other psychosocial factors that are stressing the client. We can provide some context with the family and the setting that they're living in and address some of those barriers. We can often be that source to help patients taking medications, working on a compliance planning, going back to patterns, addressing alternatives, and then developing plans. That often doesn't happen in a primary care visit in the short term. It takes work. It's not just people with substance use disorders that have trouble with medication compliance. It's most people. And in our role always is to ensure that patients are receiving high quality care. Next. This is kind of a last thing I'm going to kind of end on, and I'm going to be done. I know some of us out there, we provide group, and we provide group therapy for those people who are on MAT, as well as those people who may not be on MAT. And that can be a complicated situation to walk into if you're not prepared. And why I talk about this is because as we use more medication in the world, we're going to be working with clients where it's much more commonplace. When Hazelden and Betty Ford in 2012 developed their Core 12 program, which stands for Comprehensive Opioid Response, and with the 12 steps, that's the 12. When they did that, they identified there's going to be medication tracks that people are on, and that can be things like buprenorphine and Vivitrol or naltrexone, and as well as non-medication. What that is determining is what medication they're on, but not the services they get, not the psychosocial treatment that they are provided. They were continuing to provide services to patients who were on medication and those who were not in the same setting. And that's the model that many providers use, as well as Bradford. But what happens is that can create a cultural shift if you are representing an agency that has one opinion versus another about medication, if you're using it as part of your setting or not. So if you are at the precipice of making changes as an individual provider or as an organization, know that there will be cultural challenges within your staff as well as within your patient population. What I have here on this slide are just some tips about how you address it, because it really should not be the issue that is impossible to overcome. As a group, a treatment group, we are all there for the same purpose, and that is to get better. And we have to address differences of opinion. We have to address biases, and a lot of that can be helped with education and addressing some of those underlying feelings about it, the fear or the judgment and the confusion that goes along with it from some of the other patients. We always will model positive behaviors and quality communication. We'll move on to the next slide, last slide, I think. In summary, for counselors, for social workers, marriage and family, for helpers, for whoever you are, acquire some new information, expand your skills, become more competent, understand what's going on with use disorder and medications. Always position yourself as empathic and non-judgmental. If you have individual personal beliefs about drug and alcohol use and medication options that are available, please work with somebody, supervision, peer support, get some feedback, learn some things to help you. It's our job to reinforce change, and we do that in concert with the patient's goals. We let them take the lead, and we reinforce that change, working within that idea of a flexible model and understanding this is not a short-term treatment solution. This is a long-term plan. And it needs the illness, it needs to be responded to in that way, similar to how we treat diabetes and other chronic medical conditions. And you are part of a larger team, whether that's family members and other concerned others in their lives or other treatment providers or prescribers. You're not an island, and in communication and transparency about how we're all working together for the goals, that will make for a more quality treatment experience for our patients. That is the end of the slides. We now have a few minutes. So what we're going to do is we're going to join back with our presenters we've had today to open up for some panel questions and discussion. Thanks for sticking with us so far and through some of the technical problems. And we are here to take some questions that Sherry will be feeding to us.
Thank you, Zach. Thank you all to our presenters and our participants. Like Zach said, working through our technical issues. We do have a couple of questions that have come in. Some of them have actually been answered with just the natural course of our presenters talking. I guess the first one, Brett, this one would be for you. It was in regards to poverty being a risk factor for addiction. How much of an impact does environmental factors like societal norms and poverty level have on drug addiction?
So, looking at a few studies that I was looking at when we put this together. So one of them specifically, there's one entitled Socioeconomic Status as an Effect Modifier of Alcohol Consumption and Harm. And it's a retrospective, like looking at some cohort data. It basically shows that, let me see if I can find the exact numbers in the study. It doesn't give me an exact percentage, but and part of their findings, they're saying that lower socioeconomic status was associated with consistently with strikingly raised alcohol attributable harms, including weekly consumption, binge drinking, BMI, smoking, and there was evidence that also suggested an effect on modification of these behaviors And then there was another study that talks about socioeconomic, it's entitled Socioeconomic Status, Parental Education, School Connectedness, and Individual Sociocultural Resources in Vulnerability for Drug Use Among Students. So basically, this study looks at all these factors, and it shows that there's a multitude of factors that can cause people to have addictive potentials, but socioeconomic status is one of them. I think to be clear that the question specifically, I believe, asked about it crossing all socioeconomic lines. It does cross all socioeconomic lines. It's just as socioeconomic status changes or goes down, there's a increased risk of people having a substance use disorder. Not to say that that's the only attributing factor, but it is an attributing factor. There was one other study, and this is an older study, so I didn't use it as much, but it's a 2013 study that specifically looks at neighborhood socioeconomic status and substance abuse by U.S. adults. And they looked more at drinking and marijuana use, but they also included other drugs. And what it's showing is as socioeconomic status decreased, there was an increased risk of drug use. And specifically, it was roughly, in most everything they looked at, double in lower socioeconomic neighborhoods. So I think the biggest thing to remember is that's just a risk factor. It's not a determining factor of if somebody will have a substance use disorder. Just like, being overweight is a risk factor for people to develop type 2 diabetes. It is not a determining factor that they will develop type 2 diabetes. So yes, type 2 diabetes can cross all socioeconomic or all types of bodies. It doesn't have to be just patients who are considered obese or have an increased BMI. And same thing can be said for substance abuse. It doesn't just affect, socioeconomic or lower socioeconomic communities. It has an effect across all ranges of socioeconomic status. It's just an increased risk factor for patients who come from a lower socioeconomic background.
Thank you, Brett. Jennifer, I guess this question would be better for you. Who is eligible for medication-assisted treatment, or what type of medication-assisted treatment is determined for particular patients?
So patients that have an opiate use disorder, classified as moderate to severe, or an alcohol use disorder, they would qualify for medication-assisted treatment. And then were you asking what medications or?
No, how is it determined what patient is appropriate for either of the three types of medications, whether it's the Vivitrol, Suboxone, or Methadone?
So each facility would do things differently, but here during the history and physical, when they meet with the prescribers, they're given a diagnosis on admission. And once they're given that diagnosis, then we meet with them and give them their options for medication-assisted treatment. And take into account what their discharge plan is, if they're going to go to like a sober living that allows buprenorphine or doesn't. That sometimes drives what medication they choose. And then we work with the counselor as well, so that everyone's all on the same page about what kind of medication-assisted treatment that they're going to do.
All right, Zach, this one's probably best for you. We've had several comments about the stigma of the use of medications for opiate use disorder or addiction treatment. How can a counselor respond to a family member who is against their loved one being on medication?
Yeah, I mean, stigma is something that we've all faced in our roles of working with MAT, whether that's from staff, patients, or families. The first place to start is always with education, with making sure that people are getting the correct information about the medications and how they work. There is so much misinformation out there, so that people don't understand the reactions and what to anticipate from their loved ones. Doesn't mean that they have to have the master's class in the psychopharmacology, certainly not, and I'm not equipped to give them that lesson either, and Brett's busy a lot of the time. but what are the basics that they need to know and how this medication can help? Recognize that usually they're coming from a place of fear and anxiety. They've seen their loved one going through substance use disorder, and they face the consequences of it, and their families face the consequences of it. A lot of times families are looking for solutions, and this is part of the solution, and they have to understand that that's what it is. It's part of it. It's not the silver bullet. It's not going to make everything go away, but it's a starting place for stability. And when your loved one is stable, here's how they're going to act versus when they were in their active use. And when we work together, and this is then the opportunity for now we incorporate them even further into the treatment plan. What are they going to do? What are we going to do? When we work together, what are going to be our joint goals as a patient, as a family, as a provider?
Thank you. Amanda, this one just came in. What would you suggest as a counseling strategy or kind of working with a patient, and Zach, you can hop in on this one too. For a patient who has been on Suboxone, they were tapered down from 2 films a day to 0.5 films a day, but just can't seem to get to 0 and is verbalizing that they want to completely discontinue the medication.
Well, I think first, I would want to ask them why, like what's preventing them from discontinuing. So why do they feel like they need to? Are they having withdrawal symptoms? Because there's other things that we can give to address the withdrawal symptoms. There's different medications that we can give them to help with the symptoms that they're having. Or is it that they have fears? And in that case, that would be more of a question for Zach, like what kind of strategies you would address, those kinds of things. But as far as if they're having physical issues or other issues, like medical reasons for not wanting to come off of the medication, then those types of things we can address in other ways. There are non-narcotic medications we can give them for the symptoms. But if there's other issues, then that would be, more of a counseling question that Zach could probably answer.
So I think I heard it right of they're wanting to come off of the medication. Okay.
Yeah.
I mean, Amanda's question was correct of, why are you struggling to come off the medication? I would also ask the question of why come off? I mean, at this point, if they have some level of stability, is something working for them? The fact that they're wanting to come off, it sounds like something isn't working. Don't know what that is yet. Got to find out. Maybe they don't want to pay for the medications anymore. Maybe they just don't like the thought of taking a daily medication. There's lots of reasons why people want to do that transition. I will say, just from my experience working with people who have made that transition at an outpatient level, that is a difficult thing to do. Tapering down is quite a journey, but often that last step, that carries obviously the physical symptoms, because they're the absence now of the medication, they will have a response. But a lot of times there's a real psychological dependency, I'll use that word, with the medication. They've become accustomed to it. There's a predictability that comes with it. And just an alteration, people report that they are having significant increase in using thoughts, dreams, cravings, and I believe all that's real. But there's also just the security factor, and now we're doing something different. When people make that transition, it really is an all hands on deck situation. And there, as a provider, I love to have the involvement of family or people that can be supportive, because moving from Suboxone to nothing carries its risk. I mean, you've gone from the safety of a regimented medication to nothing. And we talked today about what happens if you've been going with medication, your tolerance decreases. If that person relapses without the safety net of any medication, they are at very high risk of an overdose. And so when people I've worked with have been dead set about getting off, I'm like, family, you got to sit on him for like a week, and then I want him back, and we're going to put him on Vivitrol. And we're going to put them on the monthly shot. Then, all the concerns about taking a daily medication and all that go out the window, and that gives us a new security. Not 100% obviously, but it helps a lot with some of the things we talked about. It's a process, and I think I mentioned that during my session of, long-term medication is very effective, and we shouldn't be regimenting when and how people get off the medication. But when we are getting to these situations where people do want to get off the medication, we got to be really transparent about the challenges that are going to be there. It is not a rose-colored glasses situation where it's going to be easy. It does take work, and it does take involvement of helpful people.
Okay, thank you, Zach. Last question, and thank you all for hanging out with us. Last question, anybody can answer this. It's regarding methadone and the stigma with that. Somebody been on it for a long time. How would MAT be justified with valid concerns of what the typical methadone clinic stigma holds?
I mean, I'll maybe get the ball rolling. I think methadone gets a bad rap, and in my opinion, my professional and personal opinion, it's often not justified. It is a medication. It does serve a purpose. The way that the medication works, though, as a full agonist, we're talking about it in a different category than we're talking about things like buprenorphine. And because of the way it acts, you do have to increase doses the longer someone's on it, because it stops being as effective. And that can create challenges for people who have been on long-term maintenance of methadone. And I know Amanda talked a little bit about how we try to serve some of those folks. Can be very challenging because the extended detox from that does take quite a bit of time. Carries a lot of challenges with it. When people get on such a high dose that it's hard to make some quick changes to that. On the flip side of it, methadone is indicated in a lot of situations where people with people's individual needs and health. It is the #1 recommended medication to be used with pregnant women, so it certainly has its applicability. There can be benefits gained from the way that the medication itself is regimented, where often people can have daily dispensing. And that has its benefits versus other medications where people might get doses prescribed to them and dispensed to them that, they get a week's worth of medication. If they're not good about self-administering that, and they don't have anyone in their life that could administer that, methadone makes some sense. So everything has its place. And I know that probably didn't fully answer the question, but I thought I'd get the ball rolling.
So I wanted to go ahead. I saw a question from Toria that I wanted to go ahead and address also. It says, has anyone ever overdosed on an opioid post receiving Vivitrol? And is it most effective for preventing relapse, primarily with those that are homeless, and is it expensive? Okay, so it is expensive. I'm going to let Jen talk about that. But so there is always a risk of overdosing, period. Like everyone can always attempt to override anything that you do, right? So that was probably our greatest fear when we first started learning about Vivitrol is if you know anyone that has any sort of use disorder, they're going to try to, get by any kind of protective factor, right? That's what they do. That's part of the disease process is can I get by, this thing that's been put in place? Can I break the rules? So that was kind of our fear is would they do that? But that's why we try to do a lot of education. I have not found, and we've been using Vivitrol for years and it's been implemented for years. I have not seen any studies come out about like multiple, attempts at overdosing after receiving it. Like during that 28 days, I have not seen a lot of cases like that. I have not had any experience with our particular patients or anything like that. So I can't really speak to having experience like that. Now, after the 28 days, after it wears off, if they don't get their next injection, they are highly at risk for a fatal overdose because they're opiate naive. And if they go back to using again, then they're absolutely at a high risk to overdose. So that is something that we talk about with them on admission, that we reinforce with them at discharge, that we give them education about, because it is very important that they understand how at risk they are for overdose if they, are using after being opiate naive for any length of time. So it is very effective at preventing relapse. Like I said, if you can get someone to the 10 days after their last dose of Suboxone or after their last opiate, then it is essentially as effective as buprenorphine in preventing relapse and achieving longer term sobriety and recovery. So all the studies show that it's about as effective as buprenorphine. The issue is that it takes getting people to that 10 days of nothing. They have to go 10 days without anything is very difficult in that patient population because of the withdrawals that they experience. You have to have that. There's only a certain amount of people that will make it the 10 days. So that's what takes some time. You have to really pick out a good patient for that and have some kind of, like medications in place for any kind of secondary withdrawals and things like that. So that, and have protective factors in place, like maybe they stay in treatment a little longer, maybe they have, somewhere to go so that those 10 days that they don't have anything, they don't have Suboxone, or they don't have something else, that they don't relapse while they're waiting on their naltrexone and Vivitrol. So you have to have that backup plan to prevent them from relapsing during their wait time for their Vivitrol. So that's really kind of the protective factors that you have to think about. But once you get to that point, then yes, it's as effective as, buprenorphine in studies. As far as the cost, I'm going to let Jen cover that because she is most knowledgeable about cost. She takes care of that for our patients.
Yes. So it is an expensive injection. However, the pharmaceutical manufacturer Alkermes has a patient assistance program, and the number is 1-800-VIVITROL. And what you do is you call, you request a patient assistance program application, and you just have to provide the patient's information along with, if they're homeless, then they probably are not filing taxes or don't have any proof of income. So there's another form that they send with the application that your prescriber will just complete to notate that the patient doesn't have any income and we don't have any way to prove that they don't have any income. And then you send it in to Alkermes. They review the information. Basically what they're looking for is to make sure they don't have any other health insurance or don't have any health insurance whatsoever. And then once they approve it, if it is approved, they'll get 6 injections for free. And you would just have to, after those 6 injections, reapply for the patient assistance program. So if you have patients that are homeless, that don't have any income, that are unemployed, Vivitrol can still be an option for them. It just may require a little bit of extra paperwork on your part.
Great. Thank you, Jen. That was very good information. So thank you all again for attending and hanging with us through our technical issues. That concludes today's session. Please remember to be on the lookout for a post-session email with materials from today's presentation. So it will include the PowerPoint. It will also have information regarding contact information and evaluation to complete your CEU certificate. We hope you can join us for future topics scheduled this year. I hope you all enjoy the remainder of your day. Goodbye.